We, all right, welcome back, everybody. We're going to start the evening sessions, at least evening here in Los Angeles. Miguel, are you there?
Hi, how are you?
Good. Thank you, Miguel.
Thank you.
So why don't we start with you speaking in the session, and you can feel free to share your screen.
Okay, perfect. Awesome. Thank you.
Thank you.
Okay, should I start now or?
Yes. Yes, go for it.
Thank you very much. Okay, thank you very much for the opportunity to share our project. My name is Miguel Barbosa. I'm talking on behalf of the LACE, the Latin American Stroke Registry. And this is basically a short protocol that we've been working on in the last months related to mortality and functional predictive model to compare our own results with the results from different randomized control trials. So as we know, in Latin America, there are a few protocols related to acute reperfusion therapies. As a matter of fact, Resilient is one of the most recent that has been done in the public healthcare system in Brazil. And a part of that, there is a bias in terms of the amount of information that we have related to reperfusion therapies. So comparison between stroke populations, not only in Latin America, but especially in those low income and middle income countries, typically suffers from baseline factor imbalances. And also, some of the predictive models that have been done have been developed before IV thrombolysis recent protocols. And most of them have been already done only based on NHSS and H, and they haven't been taking account. They haven't taken account new information from recent randomized control trials. So we intended to provide a platform to compare outcomes of a Latin American-based registry data, which is the one that we have from the Latin American Stroke Registry, compared to Resilient protocol. Basically, a randomized thrombectomy-based trial from the same region, again, against model derived from RCTs with different baseline characteristics. So LACE is a registry which has been collecting data from different centers in Latin America. It's a multi-center initiative from 9 countries in our region. We have 17 active centers recruiting data, and we have been collecting patients since 2019. So the first part of the protocol, we perform our systematic review, identifying and we identify randomized control trials that provide median NHS, mid-age percentage of patients receiving TPA, time to randomization, and also 90-day MRS 0 to 2 and mortality. With this information, comparing all the available data, we perform basically we perform a model using the ICAC information criteria on an information theory construct to select the best model against 15 different combinations of 4 variables. You're going to see that in the results section. Taking into account that the information was compared in a 90-day outcomes of LACE and Resilient, and also it was plotted in a model. The model with the smallest AIC is chosen as the best model, and other models that had also AIC with 2 of the best models will also consider as plausible alternatives. And I'm going to show you the current model that we have already online. It's free. You can access to the model to input your data and to compare your own cohort. So you can put your data that you can compare. For example, I can put that my data for my own cohort has a median baseline NHS 9, and we're going to do, for example, the model for MRS. I can say that we have 25% of MRS 0 to 2 in our model, and we have I don't know, 10% IB TPA in our cohort. So we have the information for MRS in the plot. This is our cohort right now, and you can compare all your data, and the model is available online. Okay, so these are the different models that we included in our construct. As you can see, for mortality, the one that had the best IEC was mortality compared with NISSH and percentage of TPA, which is the one that I already showed you, and also the different models that we already proved. And this was also compared for MRS 0 to 2 with functional outcome. And in balance at the end of the models, this is the one that we choose. Now, with this model was created using the 34 randomized controlled trials available and already published, nearly 1,300 subjects that were identified. And these models were, this data was used to consider the most optimum model in terms of the IAC. Our registry has nearly 3,600 patients, and 950 were candidates for the model that received TPA alone, 127 that received TPA and mechanical thrombectomy, and 101 that received MT alone. And the information from our model was also compared with the resilient outcomes. And as you can see here, these are the three first models. The three first life science are from the LACE registry, and these two are from the resilient thrombectomy arm and control arm. And for the MRS 0 to 2, and for mortality, we have here the information. In our data set, which is an observational data set from different countries, the TPA alone group was in the middle surface for MRS 0 to 2, which indicates that the outcomes were in line with the RCT informed model. MT alone, which was absent of TPA, and MT plus TPA, and the resilient arm were above the 90% surface for the confidence interval, indicating superior efficacy compared to non-mechanical thrombectomy. And interestingly, in our analysis, the resilient control arm had more expected mortality than the one that we use, the data from our data set, suggesting harm, in terms of the comparison of the other models. Well, mortality of our arms was within the 90% intervals. Now, this is basically a model, and the reason that we developed this is because, as you know, especially in low-income and middle-income countries, we lack from resources to sometimes start stroke networks based on mechanical thrombectomy and advanced stroke network. So one of the main reasons is to show our governments and also our health systems that despite these problems, we are intending to do things according to what the randomized controlled trials have been doing since the last years. So we successfully leverage information theory concepts to select the best models for the functional outcome in this case, and also mortality from several alternative models derived from randomized controlled trials. This information is important in terms of what has been already published, because most of the models include also glucose as one of the variables, but in our model it was not a very important variable. So it's easier in terms of how to use and interpret our information, and also the availability of the model for example, a post-matching process to compare your own cohort is also very easy to use. Now, functional outcomes and mortality of patients from the last resilient trial that received MT and MT-TPR compared favorably to native functional day and mortality seen in a model derived from strong randomized controlled trials, indicating that the Latin American systems of care are comparable to those in more resource regions. And as another finding, we had a small higher mortality from control arm, only TPA, the resilient trial, which requires further investigation. And one explanation could be related to the hyperscalation of our model, which also could lead to this percentage of mortality. So this is what I wanted to share. It was a very short presentation. The idea is to present what we are already doing, because now we are comparing in a individual patient post-matching model with resilient and the rest of the patients from our dataset. Thank you very much.
Thank you. That's excellent. I was just wondering, how do you coordinate all these? Is it 15 countries you said, or
17?
17 countries. Is there? And I would expect you'd have a very large input from bigger countries like Brazil, for example, as opposed to Costa Rica. Do you have your own numbers at all? How many thrombolysis or thrombectomies you're doing in your country?
Yeah, well, this trial started with 17 countries in the first phase. We have this is the retrospective phase where we collect all the data. Now we have the prospective part of the protocol, which is intended to collect more data from different centers, especially from Brazil. As you say, Brazil has a huge amount of centers collecting data and also doing thrombolysis and thrombectomy. They have the highest and the biggest strong network in Latin America. Right now, for this part of the protocol, we have as a total 3,600 patients collected from the different centers. For example, in my country, in Costa Rica, right now, the current retrospective data set has 808 patients. And from those 808 patients, we have nearly 300, something like that, thrombolyzed. But this is a small data that we collected in the retrospective phase. Now we're collecting data from prospective in a prospective manner to include more cases.
Excellent. Now, is Mexico also included, or is it?
Yeah. We have 3 centers, but only one of them is a big tertiary center, which is the National Institute of Neurology and Neurosurgery in Mexico City. The other 2 are stroke-ready centers, but they receive a small amount of patients. We are increasing the registry, and there has been many people invited. As a matter of fact, in the next months, we are intending to increase our network to nearly 30 centers in the new last version.
And the data is sent in. This is volunteer data. There's no.
Yeah, it's volunteer, and it's a centralized data set, which is also approved by the National Institute of Neurology in Mexico, which is right now the managing center of the protocol.
Excellent, Miguel. Wish you best of luck.
Thank you very much.
Do we have Carlos on? Carlos, are you on? Please feel free to start sharing your presentation.
Hello, I am Carlos Sabanto from Peru. Can I share my presentation?
Yeah, go ahead.
Thank you very much. Well, thanks for the kind invitation. I'm going to talk about an implementation of telestroke in Peru. Well, Peru is a country in South America where stroke prevalence is 0.47 cases per 1,000 inhabitants and an incidence of 85 to 87 cases per 100,000 inhabitants. In Peru, stroke is the second cause of mortality. We have 33 million people, and Peru is in the center of South America. Well, I work at the National Institute of Neurological Sciences, where we began elaborating a telestroke guideline. It was in the COVID times, where a place that was a classroom became a telestroke center. But at that time, we had the opportunity to use a smartphone application called Join. So through that, we could send messages, DICOM imaging, and also video calls. We had the opportunity in COVID times to have a pilot, and well, it functioned well, but not all over the country, just in a part of the country. Especially, we discussed stroke and COVID. After that, we downloaded in an Excel datasheet, and we could have some data about that as a pilot. For example, we had a mean of door to needle of 60 minutes, and in that pilot we have 50. Well, the hospital director decided to allow us to have an inauguration of telestroke unit in 2020. But it was just a pilot. We wanted to spread it nationwide. And we worked with the Ministry of Health in a timeline in 2021 and 2022. We did a selection of some centers that have an excellent internet, digital CT scan. We have PACS, Alteplace, and especially the team, 24 hours a day. We selected just a few centers because there was no money by the Ministry of Health to manage that. So we selected some centers that already have all these requirements. So we visited by Zoom meetings or in person in all over the country, the centers, to see if they fulfill all the criteria, and elaborated parallel national guideline. It was published this year by the Ministry of Health portal, and presented in the Ministry of Health in March 9, 2023. Well, the goal of that was to contribute through telestroke to reduce mortality and discapacity. And we did some activities. Specific aims was to telethrombolysis to have referral patients for thrombectomy, also to treat patients that not require TPA in the acute phase, and to have capacity building with all the personnel. Parallel to that, we participated in the certification of stroke centers by the World Stroke Organization. We are already promoted that in Peru. And our center had the certification of an essential stroke center. Well, for you to know how in Peru is the TPA, for example, in the 2019, we had 5%, and nowadays from 9 to 10%. Well, we know this is not good, but with telestroke we plan to double that quantity. So we worked in teams from the Ministry of Health on telehealth, hospital that have stroke units, and different departments. So we began working at the first phase in capacity building to centers in Lima and also in some regions in Peru. And now we have really a problem that the budget is limited. So now our next steps are capacity building. We are promoting stroke teams, remote 24 hours over 7, telestroke pre-hospital services, the SAMU, and we have two middle term outcomes, that is improve door to needle to 45 minutes. Currently we have 60.1 minutes. To improve percentage of thrombolysis to stroke patients, now we have from 8 to 10 to 16% in a year. That's it, and thank you very much. And do you have any questions?
So the question I had was, how many centers do you anticipate you'll have as part of your telestroke centers, the ones that are in the periphery?
Yeah, we have screened 37 centers, but now we are working with 5 centers. The problem was, or is, internet, but now, according to Ministry of Health, we are using everything we have in hand as telephone and another different technology, not only internet. Unfortunately, we don't have optic fiber, but we are working with 5 centers now.
And for these centers, the physician in the emergency department locally at those 5 centers, would those be emergency doctors or are they neurologists?
This is a good question. Most of them are emergency doctors. We are promoting that neurologists go to emergency.
And the imaging, is it a PAC system where you are able to see these in Lima, all these images? Yeah,
this is the ideal way, but the PAC systems are not allowed by the owners, by the companies that sell the CT machines. We have to have permissions. So we are using mostly a portal web system or join. But we know the ideal form is the PAX-to-PAX connection. We did with just one center, but the other centers, we don't have the authorization of the company that sells the CT.
And have you treated patients already, or is this in a planning phase, the 5 centers?
Yeah, this is in a planning phase. We did imaging. We see the imagings from centers, transfer of imaging. We see also the presenting the cases in a planning phase and something like pilot, not real patients. There was a problem. We didn't have a code to have an official consult with that. But now we have a code by the Ministry of Health. We are preparing to have real patients.
Wonderful. I wish you luck. This is an extremely rewarding experience. We've been doing it for more than 20 years now, and we work with family doctors in emergency department. As long as you can examine the patient and you have access to the images, it's not that difficult. And being a fairly large country, you'll definitely make a big difference to patient care. So congratulations.
Thank you very much.
Hi, I'm Amir. I'm a neurology resident. That sounds like really great work and really productive work during COVID. So I congratulate you on that. I was wondering if stroke education in the community and getting people into the hospital in time for TPA is an issue in particular or not.
Thank you. Good question. Yes. In the context of the World Stroke Day, we are doing national campaigns to have recognition of the signs and symptoms of a stroke. Also, through Ministry of Health, as part of the telestroke implementation, we are doing the education of the community to go early to hospitals once they have the stroke symptoms.
Okay, that sounds really excellent. And then one, and I apologize if I missed this during the talk, but I guess that hasn't been implemented yet, right? I was wondering if this plan has improved kind of door to groin or thrombectomy, or I guess it must be still in the planning stages for that then.
Yes, this is in the planning phase, in capacity building, and as part of the program, through Telestro, we plan to select and have referral patients to centers that have the possibility of thrombectomy through Telestro.
Thank you so much.
You're welcome.
Thank you. Excellent presentation. And just like Amir said, you guys did a great work during COVID. And this, I guess, not every terrible situation is terrible at the end, where you can make a change and improvement in healthcare all over the country due to the telemedicine. So my question goes back to thrombectomy. Are any thrombectomy centers in Peru at this time, and how are they operating? Do they have a telestroke process, or there's no thrombectomy yet?
Yes, we have thrombectomy. It is rare. In the order that we have from 1 up to 5 a year in the huge centers. Most of them are private centers, but it's not very well implemented in public health centers.
Thank you. I guess the follow-up question would be, would it make sense for you to join forces with these private centers to organize, I guess, more robust telemedicine, telestroke service, so patients can actually get to thrombectomy centers faster?
Thank you.
Thank you, Carlos.
Thank you very much.
2 days. I just waiting.
We're going to take a couple minute break. I'm going to get Santi on the line to give his presentation on tandem collisions.
Hi, Santiago. We've still got a few of our attendees getting dinner. Just give a few minutes.
Perfect. Can you hear me well?
Yes, we can hear you and see your presentation.
Yeah, I hear a little bit of echo, but it should be okay, right?
Yeah, it's just my microphone.
Okay. Perfect. And can you see the screen?
Yes, we can.
Perfect. Thank you.
Santi, are you there? Sorry about that.
Yeah. No problem.
So Santi, we have plenty of time for you to speak about tandem lesions. And Santi, I know in past years you have spoken in various country sessions, and now I satisfy your request. You're speaking in the American, not an American, the North American, the U.S. session, the Iowan session.
Yeah, you always put me in some in Ecuador session or Peru session. You don't even put me in the Spanish section, from Spain. But I'm happy to talk in any session for you, David. Whatever you need.
Okay. Well, then we're going to designate this as the Iowa specific session. Okay.
Very good. No, thank you so much.
You're wearing an Iowa sweatshirt? No.
Yeah, I do. I am. Yeah.
Perfect. Okay. That's perfect. So Santi, go ahead. You can share your slides again.
Very good. Can you see them now? Perfect. And first of all, congratulations, David and Andre and the team for such a marathonian 4-day conference. Plenty of high quality science. Thank you for sticking with me in such a late time. I was supposed to speak the first day, but unfortunately, Tudor talked too much. Therefore, there was no time for me because I had to catch a flight. And David asked me to please just share with you some of the new updates on what we have done this year with the US tandem lesion registry and some of the new science that we have put together. And over the next 10-15 minutes, I'm going to talk about tandem lesions. The main disclosure that is affecting this talk is I'm the PI for the US tandem registry. And most of the papers presented here are the result of some of the publications we got there this year. First, we'll review a little bit of the evidence for safety and efficacy of the endovascular treatment for tandem lesions. And then we'll get some new evidence for the subgroups of tandem lesion patients, including patients who receive TPA, patients who might have some different types of antiplatelets, and the tandem lesions presented in the late window and a very late window. The first thing we need to remember is that the only randomized data that we have about tandem lesions probably come from from the Hermes meta-analysis, in which even though the majority of trials did not or excluded this patient population, there were a total of 122 patients with tandem lesions. And what is clear from this data is that treating these patients with mechanical thrombectomy is the way to go, and the effect size of treating these patients is comparable with the effect size of isolated LVO patients when thrombectomy is performed. However, we have no idea, based on the guidelines and based on the information of these trials, what to do in terms of the technique to treat the endovascular, the cervical lesion. We don't know what is the optimal antiplatelet regime to use, and also in the early window patients, if we should actually put a stent in the context of giving these patients thrombolysis when they get when they qualify for it. Therefore, what we're going to do is first, I'm going to show you how bias or how much equipoise we have in this specific topic. This is a survey that we performed in 2021, and we included a total of over 200 cerebrovascular experts from all different backgrounds. The 6 continents were represented, but the majority of respondents were for North America, Latin America, and some of them for Asia. And we asked them several questions, but the most important question we address is, what do you think in a tandem lesion should be the cervical treatment that we should provide these patients with when they come with also a concomitant LVO? And 41% thought that in the acute setting, stenting is adequate, whereas the other 59% thought that maybe balloon with suction, or suction alone was the way to go. Therefore, even between cerebrovascular experts, which included neurointerventionalists from the 3 specialties, as well as vascular neurologists, as well as neurocritical care experts, did not agree on what the right technique is. And when we asked them why not acute stenting, the majority coincided that the fear of intracerebral hemorrhage, because most of these patients require antiplatelets in the context of acute mechanical thrombectomy, was the reason why they prefer to do angioplasty in this context. But do we have any data to support this? Well, the oldest data probably come from 2017 from the STRATUS registry, which, as we know, is a single-arm prospective registry of about 1,000 patients with mechanical thrombectomy, of which 147 had tandem lesions. 67 of them were treated with angioplasty or other methods, whereas 80 of them underwent acute stenting. And this is the first time that when they compared these groups, it was observed that patients with acute stenting had a significant improvement in functional independence at 3 months, comparing with the patients who did not get cervical acute stenting. And more importantly, there was not increased risk of symptomatic ICH or mortality. But again, this is just retrospective data from a prospective collected database. And what happened afterwards is different groups, including the European groups and our group in the US, wanted to kind of ask this in a more multi-center fashion with specific registries for tandem lesions. This is probably the one of the largest papers published in 2022 from the Titan and ETIS registries, in which they had a total of 600 tandem lesions. And those tandem lesions were divided in the patients who underwent acute stenting versus not acute stenting of the cervical lesion. We need to understand that all these patients had also an concomitant LVO, which was treated with mechanical thrombectomy using adequate techniques, whether it was aspiration, stenting, or combination. It was not very clear in this registry. But the most important thing here is that this is the first paper that showed that acute stenting was associated with better outcomes in the shift analysis, as well as in the proportion of patients achieving MRS 0 to 2 at 90 days. More importantly, and similar to what it was shown in STRATUS, there was not an increased associated rate of mortality in patients undergoing acute stenting after the confounders were adjusted by using the IPTW method, which is a sophisticated method of performing matching. Also, even though there was a trend to higher symptomatic ICH, there still was not significant in the patients with acute stenting. And this is what we just decided to do here in the US. We did also a multi-center registry with high volume centers. Many of you probably were participating. Thank you for the support. And in this, we actually got a total of 623 patients that had a tandem lesion with concomitant LVO. 363 underwent a stenting of the cervical lesion in the acute setting, whereas 260 had other types of cervical approaches, including angioplasty with some suction, also just the mechanical pushing with the guiding catheter, and or no treatment whatsoever, just mechanical disruption with the intermediate or guiding sheath. And the results were actually very similar. In fact, the effect size was a little bit larger than the ETIS and Titan registry, with almost 16% effect size in favor of patients that underwent acute stenting without a significant increase on the rate of symptomatic ICH, and a very noticeable significant increase on the rate of successful reperfusion compared with the patients who did not undergo stenting. And when we look in the subgroup analysis, there was no interaction between any of the groups, and this effect was seen independent of age, treatment with IV thrombolysis, the aspect that the patients presented with, although the majority of these patients had an aspect more than 6. The treatment that was used, if the patients were approached anterogradely, which means first you treat the neck and then, or retrogradely, first you treat the LVO and then the neck, or if the stenosis, it was a stenosis or occlusion. These data actually were in conjunction with a real-world data also done by our group, in which here we got a national inpatient readmission database from 2017, and from the 2,042 patients that underwent tandem lesions, it was observed that from the 1,391 in the US underwent acute stenting, whereas 651 they got angioplasty or other methodology. And what it was noticeable is that there was no significant difference before and after adjusting for confounders on the rate of hemorrhage or death, or the composite of both. And patients who had acute stenting seem to have a better discharge disposition. As you know, in these databases, we don't have the ability to have a 30 or 90 days outcome. And the most important surrogate we have for functional outcome is the discharge disposition after hospitalization. These data also are comparable with this meta-analysis also that we performed, in which we had most of the literature available, with the exception of the data from our registry, in which from nearly 1,000 patients in this meta-analysis, we noticed that again, there was acute stenting was associated with a successful reperfusion as well as improve functional outcome without the risk of increased symptomatic ICH or death when performed acutely concomitantly with LVO mechanical thrombectomy. But as we all we've seen in this conference, we need level 1 data, and for that we need randomized trials. The good news is that we have already 2 ongoing randomized trials. There's going to be another one starting in Netherlands very soon. The ones that are ongoing is the Titan trial, which is primarily happening in France, and is testing or trying to assess the superiority of mechanical thrombectomy and acute stenting in patients with cervical tandem lesions versus thrombectomy alone, or other techniques that are not acute stenting to deal with the cervical lesion. Similarly, our colleagues from Canada, they are also right now having or performing the ESITOC trial, which is testing the same hypothesis, very similar design. Outcomes are slightly different, but hopefully within the next couple of years, we have a lot of information about how to deal with cervical lesions. We have a higher level of evidence, and we'll be able to see if what we've been studying with these multi-center registries that demonstrate that the stem might be superior, indeed, this is real. But what about in the curve, since we don't have level 1 evidence, what do we do in the situations in which we deal with in daily basis with patients that come to us with tandem lesions? One of the most common questions we ask ourselves when we are dealing with these patients is, well, if the patient comes within the first within the early window and they qualify for TPA, does this automatically exclude them from getting acute stenting because of the fear of combination with between antiplatelet medication and TPA and the risk of potential hemorrhage? Well, again, our colleagues from Titan were the first studying this hypothesis, and early on they showed that patients who actually were treated with acute stenting and they actually had IVTPA did not stand to bleed more comparing with the ones that didn't get TPA and presented within the early window. By the way, Titan only included patients within 8 hours of from symptom onset. And in fact, patients who actually did get IVTPA, there was a clear trend, although the patients were the sample size is very small, but there was definitely a significant trend towards decreased mortality. They also saw that patients who underwent IVTPA in the early window, IVTPA itself was a predictor of successful recanalization in conjunction with other very well-known predictors such as aspect more than 7, extracanal stenting, or low NIH at admission. We actually tested this same hypothesis in our database, in our US registry, and we were able to see that a total of 218 patients had IVTPA, and we compared them with the ones that only had mechanical thrombectomy, and obviously all of them had a tandem lesion treatment. And we primarily assess safety, defined by the rates of symptomatic ICH, PH2, or hemorrhagic transformation, any H1 or H2. And secondarily, we also look at functional outcome and successful reperfusion. And interestingly, they didn't seem to have, we didn't seem to have a difference in terms of rates of symptomatic ICH before and after adjusting for confounders in the patients who had IVTPA compared with the ones who didn't. And there was no difference in the PH2 rates either. It was very consistent with this, also the rates that we see in isolated LVO when they present in the early window. When we look into subgroup analysis, the only thing that we notice is perhaps there was a trend towards higher rates of symptomatic ICH when patients who received IVTPA were also given IV antiplatelets, and that trend didn't seem to be that interaction did not seem to happen when it was the patients were given dual antiplatelets or single antiplatelets. And finally, when we look into MRS at 90 days in the patients presented only in the early window, IVTPA was actually associated with higher rates of independence compared with the patients who did not get IVTPA in the early window. Therefore, perhaps, and again, we now can hypothesize a lot based on the choice results, based on this reflow phenomenon that we are all talking about, that perhaps maybe there was some benefit of giving IVTPA early on in these patients or not, and might have contributed to better outcomes. But what is clear is that they don't tend to bleed more, and that's the main fear from people to give IVTPA and antiplatelets in patients with tender lesions that might need a stent. What about what is the best antiplatelet regime? We know early case series and case reports really show that perhaps the combination of integralin or tirofiban was associated with higher rates of hemorrhage. But later on, when those regimes were appropriately compared in retrospective data, like the one we have here from 2015, it didn't pan out to be completely true. And the rate of symptomatic hemorrhage and PH2 and PH1 was actually very similar, independent of the antiplatelet regime that patients with tender lesions were receiving, whether it was integralin alone versus agastat with dual antiplatelets versus aspirin and Plavix, or as the Europeans do a lot, just IV aspirin combined with heparin. And as you can see here, we didn't see any major differences in terms of symptomatic hemorrhage. Because of that, we actually decided, given our large sample size, to really do a study that we presented in the stroke conference this year, and we actually saw that indeed the rates of large groups, almost 150 patients in each arm, and when we compare the rates of symptomatic ICH here in a red bar, PH2 or petechial hemorrhage defined by H1 or H2, the rates were very similar in all the groups, whether they took no antiplatelets, which was the reference group, single or oral antiplatelets, dual or antiplatelets, Plavix aspirin or ticagrelol aspirin or prasugrel aspirin, or 2B3A inhibitors. There was no really significant difference. And what it was clear, as expected, whether this is from just the antiplatelets or from the stent, still remains to be seen, but they had higher rates of successful reperfusion and better outcomes when they receive a stent and dual antiplatelets or IV antiplatelets. These are very interesting results, and this might be the key why the acute stenting and in combination with aggressive treatment, antiplatelet treatment, might be the reason that we see some effect in functional outcome. This is from the group of ETIS, and both studies are very similarly designed, very overlap of population. But basically, what they are doing here is compare the patients who underwent acute stenting. And as I mentioned, in Europe, it's a common practice to use aspirin alone intravenously or aspirin plus heparin. And when they compared those two regimes with the aggressive antiplatelets, which included dual oral loading in the angio suite or before, or IV antiplatelets given during the procedure, which included any 2B3A inhibitors or cangrelol, it was shown that the main difference, the main significant difference in this small sample group, which only included 63 patients in the aggressive treatment versus 124 with aspirin or 100 with aspirin and heparin, the main difference is the stent patency at day one. All these patients underwent a carotid ultrasound, and when you give aspirin, or when they gave aspirin or aspirin plus heparin, the rate of thrombosis at day one after the stent was placed oscillated between 14 to 16%, whereas when they were treated with aggressive antiplatelet regime, the rate of thrombosis was only 3%, 3.5%. Then that might be the key why these patients with aggressive antiplatelets might have a better outcome. We also, based on some preliminary data from our cohort, we actually observed that cangrelor was a very promising medication. And as we know, cangrelor has a lot of pharmacodynamic and pharmacokinetic advantages, especially the short half-life in case we get into trouble, and the fast acting. And what we did here is in our US registry, we had a total of 30 patients who were treated with IV cangrelor acutely during the stenting, during the acute stenting and mechanical thrombectomy. And we compare doing matching by IPTW patients with dual oral antiplatelets receiving a stenting versus the ones with cangrelor. And we focus on the safety outcomes, including the composite of symptomatic ICH, PH2, and also the rates of petechial hemorrhage. And interestingly, there were no significant differences in terms of any of the safety outcomes, petechial, PH1, PH2 composite, or symptomatic ICH, and there was no difference either, although this is a very small sample, in any of the functional outcome. Therefore, I think this is something that needs to be explored more, I think, systematic with larger sample size, because even though the price is increased, and hopefully the price will decrease when the patent expires, but this kind of medication I think might be very helpful for our procedures and will help us also out to really stop the medication when we need it, for example, in patients with large core that might require hemicraniectomy in a very fast fashion without jeopardizing the risk of bleeding during the procedure. And just to finish, I'm going to show you also some recent results we have for the late window. And some of you might ask, why are you presenting late window? We all know that late window, the effect of mechanical thrombectomy during late window, it's very strong. It's actually, we have a larger effect size because the control group did worse in diffuse 3, and we have the paradox effect as well as in DON. And the reason being is because a lot of places in the world, believe it or not, they don't treat patients with tandem lesions in the late window because we don't have evidence. The few evidence from the Titan group before we published our registry were only up to 8 hours. And they just don't go for it. Then luckily in our registry, we did not have a time limit. And we just, from these 16 centers, we actually collected any consecutive tandem lesion that was had a concomitant mechanical thrombectomy procedure during the study period. And in our cohort, we had actually 268, almost half of the sample was treated after 6 hours, which allowed us to really evaluate the effect of treating the tandem lesions and compare with the effect during the early window, which everybody seemed to agree that is adequate. And when we compare that, I see this curve really represents the effect of treating tandem lesions during the time. I mean, there is no difference. This is the probability of good outcomes at 90 days. As you can see, it's a straight line. The time does, I mean, if you treat those patients, you do mechanical thrombectomy, as we've seen in the clinical trials, and we also treat the tandem lesion, the probability of good outcomes should be the same. And this is up to 24 hours. And this is the MRS dichotomized 0 to 2. We can see 45% versus 47%, very similar during the early and late window. And also that fear that perhaps at late window, if you put them with antiplatelet medication and you treat the lesion with acute stenting, they're going to bleed more. Does not hold either scientifically, at least in our cohort. And you can see how the rate of symptomatic ICH is very similar. In fact, there was a little bit of less symptomatic ICH after adjusted for confounders in the population presented in the late window. The PH2 rates are the same, as well as the petechial hemorrhage. And that also theory that perhaps the clot is more organized and you cannot really open the vessel in this patient population is not true either. There was no differences in good TICI, TICI2B, TICI3, first pass effect, or early neurological improvement, nor mortality at the discharge of 90 days. Therefore, I think if we think that it's okay to treat patients with tandem lesions after within 6 hours, we have no excuse, because the effect of the treatment when we treat the mechanical with the LVO and the cervical lesion is exactly the same, and that is the effect that it was consistent throughout all the groups, independent of age, etiology, the aspect of presentation, the periprocedural antiplatelet regime, or the ICH treatment, if it was a stenting versus not a stenting. And just to finish, something that I think is very hot topic is, what about beyond 24 hours? Well, we also happen to have 33 patients that had tandem lesions and were treated beyond 24 hours. And I wanted to study this patient population specifically because if we think about the pathophysiology, those are the patients that are going to have, if you wish, ischemic preconditioning over time, because they're going to have, the majority are going to have atherosclerotic disease that is slowly kind of progress until they become unstable and throw a clot, or they close off completely. And when we compare these 33 patients, also by doing matching with patients treated within the first 24 hours, again, the effect of treating these patients, the LVO as well as the cervical lesion, is exactly the same before 24 hours or after 24 hours, without any kind of differences in the functional independent rates, symptomatic ICH, rates of reperfusion, or mortality. Before I leave it there, I know this is a very hot topic, and we'll soon see some clinical trials evaluating this population. But in conclusion, I think acute stenting of the proximal lesion of when patients presented with tandem occlusions or tandem lesions seems to be effective and safe based on allocation of multi-center retrospective data. Again, we don't have prospective clinical trials yet. The administration of IVTPA seems to be safe, especially in patients presented with in the early window that also underwent acute stenting without higher risk of hemorrhage. There is insufficient data to exclude those patients from IVTPA. And I think also treating patients with tandem lesions beyond 6 hours seems to be beneficial. Again, we don't have randomized data, but the effect size seems to be similar to early window patients. And we still don't know what is the right antithrombotic therapy for these patients, but the IV combinations are promising, and definitely something that we need to test in a more prospective fashion in the near future in the 2 randomized trials and further trials that I'm sure it will come in this patient population. Thank you so much for sticking with me in such a late time. And if there's any questions, I'll be happy to try to answer them. Thank you.
Thank you so much for covering such a challenging topic, especially nowadays. There's no clear-cut indications on to stent versus not to stent. I also, my practice, having challenges at times. When to stent, should I stent, should I just angioplasty? But my question to you is in terms of antiplatelet regimen, right? Obviously, starting the patients on dual antiplatelets is not really feasible in acute setting because it takes 3 to 5 days for them to become therapeutic. So we often have to rely on Cangalore or medications similar to that. What is your preference in terms of antiplatelet medication, and is there a specific one that you would recommend avoiding?
Yeah, I think this is an excellent question. As I showed there in 2 of our papers, we were very interested in testing this hypothesis. It seems that there is not major differences in terms of hemorrhage. Cangalore is very promising. Unfortunately, it's also the price is almost prohibited in some institutions, but the pharmacodynamics are excellent. In our institution, we use tirofiban, and what we do is we do half a bolus of the 0.4 mics per kilogram per minute, and then continuous infusion. We keep that until we do a follow-up imaging and evaluate if there is PH2 or obviously symptomatic ICH, PH2 or PH1 in patients who got TPA. That happens after 24 hours. In patients who don't get TPA, we do the MRI a little bit earlier. And once I see that there is no major parenchymal hematoma, then we load those patients and stop the agrastat 2 to 3 hours later. That's usually the regime we follow. We start the tirofiban infusion, do a half a bolus, and then stop it. We would look at the imaging, and then after looking at the imaging early on, if there is no TPA versus 24 hours if there is TPA, and we are assured that there is no intraparenchymal hematoma, then we just load, and then 2 hours, 3 hours later, we stop the agrastat. You can argue with me that perhaps why it only just 24 hours, but there's a potential that this patient population can bleed later. But even in our cohort, the majority of the hemorrhage occurs within the first 24 hours. And that's why I think after you know for sure that you don't have a major intraparenchymal hematoma, you might feel more comfortable loading those patients with ticagrelor, Plavix, or prasugrel, whatever your practice is.
Thank you. And when you said you load them with Plavix, I'm assuming.
We do ticagrelor or Plavix, one or the other. Usually 300 of Plavix or 180 of ticagrelor.
And do you follow up E2Y12 prior to stopping IV
No,
infusion?
you can. That's a very good question. You cannot do that because the agrastat half-life is or stays in the system for a long time, and they're always going to look that you are therapeutic. Then you can do it, but you have to wait 2 to 3 days to really see. If you do Plavix, you have to wait 2 to 3 days if the levels are good. But once you have given agrastat, you cannot check that out.
Thanks so much.
Thank you.
Hi there, I'm Amir, I'm a neurology resident, so I appreciate the very thorough review on the topic. I had a couple questions. First, I think you alluded to this with the antiplatelet portion, but what do you think is kind of driving that improved MRS in the stenting? Is it repeat strokes that patient with stents have that patient with stents avoid that angioplasty suffers from? And then the second question is, who are the patients that you would choose to not stent?
So those are very, very good questions. We have a publication hopefully coming up soon, still under review, in which we are testing that. And I think there is a mediation effect of the stenting in patients with under lesions to get better outcomes. Whether it's done, it's performed on a way that antiplatelets have a role, I think might be true, but in our mediation model, the way stenting patients had better outcomes was through better reperfusion rates. Then patients with stenting get better TK2Bs and 3s, or even better 2Cs and 3s. Then, again, and when we try to put into the model for the mediation the effect of antiplatelets, there was no mediation effect for antiplatelets. And then I cannot say. I thought initially the antiplatelets could play a very important role because perhaps help us out to dissolve some of the distal clots and help us out to get a better reperfusion rate. But whatever it is, it's related to the stenting giving us better reperfusion rates. And I think it has to do with the flow. When you perform a mechanical thrombectomy with a good anterior grade flow, is much better than if you have a very restricted flow, because remember, you're going to promote more coagulation. This happens all the time, right? When we are doing, for example, an aneurysm, and if you have an aneurysm and you start to clot, if you don't restore the flow, no matter how much TPA you give or how much antiplatelet you have in the system, you're not going to open that stent. And this is a very similar effect. I think the effect of the flow anterogradely when we do a stent might help to get better reperfusion. And hopefully that you'll see that paper coming up soon in which it seems to be mediated specifically for better reperfusion rates. And in regards to your second question about when not to stent, right now I'm actually also testing that hypothesis in one of the large core trial samples, which had some tandem lesions. But I think at this moment, the large core aspects less than 6, I'm more hesitant to really evaluate that. Although we know from For example, the rate of symptomatic ICH in SELECT-2 was very low. However, only 2 patients, but I'm still concerned about the potential association between core, infarct, and risk of reperfusion hemorrhage. Then if I have an aspect of 5 when I start my procedure, I am more hesitant to really put a stent on that patient. Other than that, and now in my practice, I have to find a reason not to do it. The majority of times I put a stent because of the not definitive, but definitely very convincing results from these 2 large multi-center registries from 2 different parts of the world, ours as well as the Europeans.
Okay, thank you. That makes a lot of sense. Just a quick to follow up to the first part of the question. Does it make a difference in terms of reperfusion if you treat the carotid first or second in that setting, or no?
That's a very good question. That paper is coming out now. We got it accepted in Journal of Neurosurgery, and it's going to come. There is no difference. I can't release that results because we also presented at the ISC. And basically, the only thing that changes is the timing. You gain 11 minutes if you do the retrograde approach, which means you go and do the LVO first and then you put the stent afterwards. But in terms of outcomes, at least with the sample size that we had, which is only a couple of 100 patients in each arm, there were no significant differences in terms of reperfusion rates, MRS, or safety profile. But you gain 11 minutes, median time 11 minutes in a kind of reperfusion time, growing to reperfusion when you do the retrograde approach at first.
Excellent. Thank you so much.
Thank you.
Santi, just a word of caution. As you know very well, that when you have limited sample sizes, you have to be careful of the distinction between association and correlations versus the causality of one factor versus another. So, when you talk about, hemorrhage association, clearly this is very different in the large core patients that you're looking then at the underlying, rate of, or subset of tandem lesions. It doesn't surprise me that the specific drug modality that's being used it maybe have a lesser or drug combination may have a lesser effect. I do believe that the flow is important in terms of what happens subsequent to the procedure, but you just have to be careful in terms of assuming that there's causality associated with one of those specific variables, because you can find a lot in a limited data set or any data set.
100% agree. These are all pure association with retrospective data. 100% agree. I just, but we did, in order to evaluate why this association occurred, we did a mediation model. But you are correct. I mean, this is just purely associations that are based on retrospective data, and only when we get a prospective randomized data is when we can make stronger statements and perhaps test better potential causality.
Right, as long as you have controlled or have proper controls for those variables across the randomization, right. Which can always be a short.
Yeah. Exactly. I mean, randomization theoretically, right, it's giving us the best possibility, but obviously any subgroup analysis in those are speculative and just hypothesis generating. You cannot make final assumptions on those afterwards, because you only are testing and creating the sample size is only based on the primary hypothesis that you are testing. 100% agree.
Right. So to treat or not treat a lesion with a tandem lesion with a certain intervention may be one thing, but other factors like, that are difficult to consider or should be considered, but they're not always considered, are mode of anesthesia. Your practice patterns. That if someone's going to treat a tandem lesion, you may decide that then, that your anesthesia practice is different. So there is more important variables and less important variables, and knowing what's, how they relate to each other is very important.
Absolutely. Absolutely. Any other questions?
No, the only comment is that you're saving, for years we've debated this. We went from a period, and I mentioned this to you, Santi, where we went from, in the U.S. we were treating tandem lesions acutely all the time. That was routine, and there was no questions asked. Then the European, mostly data out of Europe, switch gears all of a sudden. Oh, there's a safety issue. We shouldn't be doing that. And then, it's hard to remember exactly which years this happened. Europe switched back to being more aggressive in general in terms of treating an acute tandem lesion. And we still, at our place, remained very conservative. And the upshot was it caused a little bit of not a battle, but a little bit of a internal political battle because patients that were treated acutely who had a carotid stenosis, had a tandem lesion that was deemed reasonable to treat, but just not acutely, would then be on our service. And then the question was, so who do you consult about that lesion? And to be fair, we want to share amongst the different services in terms of consultation. And what would happen is, the radiologist or interventional radiologist would say, well, wait a second, we treated that patient. We wanted to wait on that patient to treat, a tandem lesion. We didn't want to treat it acutely. We should have first dibs in coming back and treating that patient. But the argument could be made that, well, you decided not to treat it acutely. You were there. So, and that doesn't mean that necessarily you have first dibs, so to speak, in terms of treating that lesion. And neurosurgery may have an approach. Vascular surgery, the one consideration is that they don't like to treat things, as acutely. So as long as you let the patient cool off, then they're very interested. But the patient has to get to that cooled off time period but before they became interested. So it became an interesting story or saga in terms of, if you don't treat acutely, then you wind up with differences in terms of, who gets involved at even at a single institution.
Yeah. Yeah, no, that's a political and not scientific question that I cannot answer because every center will have their own politics. But the good news is that all the data suggests now that you don't have to wait to do a consult. You can treat acutely, and it seems to be associated with better outcomes and not higher risk of hemorrhage. And I think we need the trials to confirm that. But I think, as I said, there is something in this procedure because it's consistent. It's not like we are seeing something and the Europeans are seeing something different. The effect size is, rate thrombectomy has a very powerful effect, but on top of it, we see about 12% effect size in those populations in Titan, in ETIS, as well as in the US registry. And I think there is something there that makes sense and probably is the improved flow and improve reperfusion rates by improving flow. And also the data I show from the ETIS registry, to me, is very also important because if you wait, just obviously there's a little bit of a caveat there because those patients did not receive aggressive therapy, but all patients, when they actually got a stent and they did not get aggressive therapy, they got only aspirin, which is a very common practice in Europe. About 15% of those stents kind of thrombose again. You can imagine what's going to happen in a plaque that is unstable. The endothelium is disrupted and has already formed a clot. If you don't put in any antiplatelets and you just wait there for days, I think there's a very high chance that you can have a recurrent event. And we know the first 3 weeks is the highest risk for a new thromboembolic event or even close completely the carotid, which, as you know, going back there in the subacute phase or chronic phase is much more challenging. Then I think we have now evidence that suggests you don't need to wait and go through that political battle anymore, and you can treat it acutely unless you have a very large core or any other finding that really precludes you to put a stent in the acute phase.
Right. So two other brief comments before we switch over to the next session. One is that aspirin does nothing, for shear stress-induced platelet aggregation. And that's why the thienopyridines, that's why Tyclid and Plavix were developed many years ago now, 30 years ago, approximately. And that acute decision about treating or not, and then subsequently what you use in terms of a medication, it becomes very complicated because so you can easily get a thrombosis if you don't have the patient on the right antiplatelet regimen. The other consideration or comment I should say is that acute treatment is perhaps one of the saving graces that's going to allow stenting to persist. Only because for a more chronic or subacute lesion, the fact is that it's nowadays it's endarterectomy or TCAR. So the role of stenting is really preserved by the acute, in the acute setting.
Yeah.
So thank you, Sandy.
Just a short comment on that, David. Sorry, we have as you know, we got the CMS approval, last week about this, and again, that debate about between endarterectomy or TCAR instead of acute stenting in the acute symptomatic stenosis is debatable because there is obviously data that suggests one thing, but there's also equipoise and data that suggests the other thing. And the most robust trial, which is, I think, in my opinion, so far, the CREST trial, which is the most accurate because it has, proceduralists that have experience in both arms, did not show any major differences between both groups. Then I think, it depends where you practice. In my shop, acute stenting in symptomatic carotid still in many instances is the first approach, and the vascular neurologists support that, as well as our neurosurgeons. And the rate of when you do a lot of procedures like that and you have a high volume, your rate of complications go down because we now have such an amazing devices from the stroke approaches that is so easy, and then we do a lot of carotid stentings through the radial approach. And I think again, I'll be careful to say that endarterectomy and TCAR is the way to go. It all depends on safety and volumes and really the right approach. But we now have some evidence that suggests that are comparable, and then as we are getting better and better, we have very little rates of complications. But again, that's a debate that it's another conference debate.
I agree that has nothing to do with the science and the data. It has to do with practice patterns and the business of who's doing what where. So
let's see what
yeah,
that would be good. Thank you so much, and
so
congratulations, David.
Santi, thank you very much.
My pleasure. Always a pleasure. Thank you.
I heard Russian rumblings in Russian behind me. Okay, so we'll start. No, I know, but you were speaking Russian? No. Okay. Okay. So do you want to start, or Ina's gonna
Maybe starting, I don't know.
Ina?
Yes, can you hear me?
Yes, Ina. Go
Can
ahead.
you see me also, yeah?
Ina.
I will show.
We wanted to give a little time so it's later in the morning.
Yeah, I'm presenting from Vienna, so it's 4:36 here.
Are you sharing your slides, or? Yeah, we could share. We see your screen.
Okay, so thank you so much, David, for this invitation to present again from behalf of Kyrgyzstan in Collaterals 2023. I will tell what has changed in the last year. I'm presenting from behalf of SOS Kyrgyzstan large work, which we have done. Now it's a young and enthusiastic team is working in Kyrgyzstan and slowly changes the things in stroke therapies for the best. Couple words to remind where Kyrgyzstan is located. It's a small country in Central Asia, bordering with a large border with Kazakhstan and south with Uzbekistan and Tajikistan, and from the east with China. Kyrgyzstan is a highly mountainous country with the peak still 7,000 meters above the sea level, and people live on several altitudes, starting in Bishkek with 800 meters above the sea level, and also in Isikul, it's 1,500, 2,000 meters, and so on. So it's a lot depends on which altitude stroke units are located. So here there are two capitals. So Bishkek is the main capital located on the north, and here is the Osh, located more in the south. The distance between Bishkek and Osh is 600 kilometers. And there is the road, Serpentine Road, if you want to travel by car. It can be quite dangerous in the winter time, but also very beautiful in the springtime. And I'm mentioning this because it's very important. People from surrounding regions could arrive to future model hub and spoke model to Bishkek and Osh, where would be located and governmental services covered hub regions with mechanical thrombectomy. But now either you drive this road or you take the flight. So our stroke units, main stroke units, are located in Bishkek, Osh, and then smaller cities, which are Talas, Isikul, Karakol, Naril, and others. And this is the main document is we call this shortly a roadmap for strokes. It was created in 2018 by WHO experts in collaboration with ESO experts and with our working group. And this is the plan for us how to proceed in next 3 and 5 years, which changes are expected. And the accent in this stroke roadmap is that stroke will be treated not only in governmental services. The accent is that it's collaboration of government and private sector, because this is only the way in Kyrgyzstan to treat strokes timely. I would like to remind that since 2016, Kyrgyzstan is collaborating with a European Stroke Organization and using a rescue stroke registry. This is the data from a rescue registry. It's around 4,000 stroke patients already have been enrolled. Before we participated in SITS registry and collected the data, which I will show on the next diagrams. Now this is a rescue registry. It's free. It's now established in 18 stroke centers in Kyrgyzstan. So this is from the roadmap diagram, what in ideal world should be happening. That hub and stroke model, like in Bishkek, the main capital, the hub would be located where with helicopters or ambulance, patient with stroke would be admitted. There would be a CT scan function and mechanical thrombectomy team. What can be reachable already now that our dispatchers in pre-hospital stroke services are trained in fast protocol, and also paramedics and medical doctors working in ambulance. Pre-notification is now in the process of implementing a transfer within 60 minutes if the call is accepted by dispatchers. Yes, the transfer can already happen. For instance, in Bishkek, it's not a large city, it's very compacted. But I will show on the next slides, it's very much depends when patient have called after the stroke onsets. And classically, CT scan should be inside the hospital covered by insurance. And first NIH would be done there, and then treatment and rehabilitation. So what is happening in the practice, in the reality right now? This is Bishkek, very beautiful city. And you see, if you drive from the center 20 minutes, you will reach already these mountains. starting with 1,000 meters above the sea level. So there are people also living and bringing animals and nomading from one place to another in summer, or have their constant houses. So you can imagine that from these mountainous regions, people will seek to get to Bishkek, either on their own transport or with the ambulance car, or with two very small stroke units in surrounding of Bishkek. So let's imagine there is a stroke patient. This patient is living in Bishkek. The stroke is happening, and now this patient needs to be admitted, and we have very strong traffic jam because there is no metro services due to high risk of earthquakes. And in daytime, it's a lot of traffic jam. Now it's additional line for the bus services, which ambulance is also using. So this is prolonging time of arrival. And the ambulance is coming to fetch patient, and what we are very proud that we implemented NIH. So our all paramedics and medical doctors which are working in ambulances to bring patient, they first evaluate on scene the patient and where they found the stroke patient. And with the very first NIH, doctors who are going to thrombolize, they orient on the very first NIH. Then this ambulance car should be bringing a patient to governmental hospital to get the CT scan for instance, for ischemic stroke, and then to thrombolytic therapy, for instance. But CT scans are not located inside the hospitals. They're located very close to the governmental hospitals, but they are only private. The situation is still like this. And then patient got CT scan, for instance, privately. Then the question is about therapy. Should he come back to governmental hospital, or what's the next? The next, if he wants to receive thrombolysis, so on our paramedic, on our ambulance services, not only paramedics, but medical doctors are working, neurologists, cardiologists, family physicians, so they are also working in ambulances. So they offer to bring patient to private center, such as private hospitals, provided TPA to stroke patients if bleeding is excluded. And if a patient can, if the relatives of patient can, he is admitted to these private hospitals for TPA, or he is coming back to governmental hospital where he is not thrombolized but treated in the stroke unit by stroke unit teams. In Osh, our South Capital situation is similar, but we also should not forget that there are regions, I assume also in Kazakhstan, there are such regions, in remote regions, where people stay in shortly or for the entire summer in yurts. If you live there, it takes very long and only by private car mostly to be admitted in the stroke unit. And logistically, the time could be prolonged from a stroke onset till arrival. What about stroke awareness? You see our typical stroke patients, they are pensioners. So we have in the last period of time also young patients with strokes. But in pensioners is accumulated known risk factors in Kyrgyzstan. This is smoking, this is high lipids in the blood. This is atherosclerotic plaques. This is untreated or not correctly treated atrial fibrillation. But stroke awareness is high because we are running constantly the stroke awareness campaigns, and patients are already aware. There are also on TV the programs and short ads to recognize the stroke. Our algorithm SOCU is working. The mega boards are everywhere. And patients see in themselves that it's very important that we remind constantly using our SOCU algorithm. So which are barriers to implement thrombolytic therapy on governmental services? As you see, as I said, CT and MRI are private. Also, next diagnostic difficulties, they're absent of TOAST. Not everywhere, not in each hospital TOAST is made. So patient is discharged, for instance, only with ischemic stroke after without subdivision on different etiological subtypes. Also, for the rare stroke etiologies, echo only use transtoracal, transesophageal, very rarely. INR done not in all hospitals. In the middle, you see the diagram from Rescue Stroke Registry. You see on the first hour, it's around 40 patients, 13% of patients who are getting a CT scan. And this is only in the first hour. If we look later in the 3 and 4 hours, the percentage is bigger, but for us it was important to look at the first hour. So the coverage with the neuroimaging is not high. Also, wide use of neuroprotectors is believed that it's concurrent with thrombolytic therapy, but it's not. It's not included in the evident protocols, but still is widely used for the treatment of strokes. Stroke awareness, as I said already, high rates of stroke recognition, but late call for medical help. Here you can see we run each year in October stroke day, and our volunteers from Kyrgyzstan Medical Academy prepare this campaign. Here we have the results. You can see the lower the NIH null with the posterior strokes or strokes in brainstem. There is 17 hours still from stroke onset till arrival. So the less and unspecific symptomatic is the later patient calls to the ambulance and later he is admitted. But if you see the severe strokes, they of course admit earlier. We also looked in pre-hospital settings, who is calling the ambulance with the stroke symptoms. You are lucky in Kyrgyzstan if you live with the children. If this is a custom, the more old people, they live with their children together. And it's in almost 30% of stroke cases, it's children who call the ambulance. In 16%, it's spouses, in 11 patients themselves, and 21 other degree relatives. But there are also neighbors, strangers, so you have luck if you are with bystanders. Then patients are admitted in stroke unit, in National Hospital and in OSH. And also we have monitoring bed, but it's not the stroke unit. It can be part of neurological unit or in smaller stroke units, part of the internal department unit. And even to standard beds, patients are admitted. And I want also to highlight several known risk factors and interesting risk factors. It was a belief till 2004 that it's ApoB is influencing on the stroke risk factors in Kyrgyz allele, but our scientists where Abay Tordobayev works from Cardiological University proved that ApoE and ApoB is lower in Kyrgyz population in comparison with other ethical subgroups in Kyrgyzstan. But if Kyrgyz population is having high serum concentration of ApoB, then they have more expressed ischemic heart disease and strokes. So this was very interesting finding. The severity of atherosclerotic lesions influenced by non-lipid risk factors. And in patients with a dyslipidemia in Kyrgyz ethnicity, there is agent smoking, main risk factors, and in Russian subethnical group, it's high blood pressure, untreated blood pressure, high density level proteins which are decreased, and type 2 diabetes. We also made, in the framework of essayist research, comparing Asian and European cohort. We found that smoking is more in European cohort, was statistically significant as stroke risk factors. Alcohol consumption surprisingly more in Asians, but as well consumption of animal fat in high percentages in Asian cohort. And in Europe, the older the patient, the more prevalence of strokes were typical for European subgroup. We also followed our patients in 7 days and 3 months. We made in 2018 first telephone monitoring. Before this, it was not done, following up the patients. And what we found, that the MRS-6 and severe disability was higher in European subgroup. The reason for this, we need to make more research. It also could be that European subgroup patients in Kyrgyzstan and patients in very late age tend to live alone. So there are no bystanders, and calling to stroke dispatcher is prolonged compared to Asian population. We looked at the stroke subtypes and MRS, and we found that in cardiac embolism, there is more higher MRS score. We also made some analysis. It's due to using of warfarin and not DOAC and dogs, or not using anticoagulants at all. Or patients using 1-2 months and then discharge or processing being without anticoagulants. What we have done, maybe I showed these slides in previous collaterals, but one more time, we translated NIH and Kyrgyz language, adapted these to Kyrgyz doctors and populations. We changed some figures in this aphasia recognition card. We included here yurt, horse, and the traditional Kyrgyz head, because our patients surprisingly were not recognizing the cactus. And now these cards are working very well. We trained a lot of paramedics. Here on the right, you can see we are on the training in Bishkek, the paramedics. Here, a lot of neurologists are sitting. They are arriving with ambulance car, and they are permitted to treat patients already in ambulance car. So if we ever will get ambulance car with the CT, like in Berlin, our colleagues, so our paramedics and medical doctors are ready to do this in the car. They already use aspect very well visually without artificial intelligence themselves. They recognize. So we trained a lot of paramedics on NIHSS, and this was the time when we implemented this in November 2019, and then next month were first cases of COVID infection, and our NIH in pre-hospital setting started to work, and we saw the first results that high NIH had patients with stroke mimics, and they were then later we discovered the COVID patients. So the high in the NIH, the trend is it could be not a real stroke, but a stroke mimics. We also looked inside the stroke mimics, which patient arrived faster, patient with seizures, something acute and bursting going on, they arrived 0.9 hours. And for instance, the longer it takes 167 hours, for instance, patient with COVID symptoms or alcohol withdrawal or brain malignancies, they tend to stand home longer and call to medical services much later. And because of fluctuating and not clear symptomatics mimicry and strokes. So here I'm finishing the presentation and welcoming all of you in summer in July and August to visit Issyk Lake. It's hard to surprise Californians with any lakes, but Here we have very high mountains. You drive 15 minutes from Issyk shore and you already can hike. So if you have any questions, I'm glad to answer. Thank you so much.
Hi, thank you for the talk. You've done really great work to highlight the difficulties in getting appropriate care to people. A couple quick questions. You mentioned there was a non-coverage of thrombectomy. Is that kind of a blanket not covered, or to what extent is thrombectomy covered? And then the second question, you alluded to some neuroprotectants. I'm just curious if you could comment on what kind of things were used there.
Regarding mechanical thrombectomy is done now in private settings. So in hospital settings, patient is asked if he is able to probably pay for thrombectomy. If yes, usually its relatives decide this. So patient then would be admitted to, for instance, Vedanta hospital, which is in Bishkek, and there we have a rare specialist who would perform mechanical thrombectomy, but it's in private centers. The devices and settings and angiographic centers are not installed in governmental hospitals, so governmental is now not yet paying for the mechanical thrombectomy. So mechanical thrombectomy is not done in governmental hospitals. But it's now in the roadmap, and we are standing on the way and really believing that maybe in the next 2-3 years it will appear covered by insurance. Regarding neuroprotectors, it's already more than 15 years. Such neuroprotectors, they extract from animal blood cells or cortex cerebral cortex of animals, such cerebral lysine, created in Austria, or cortexine created in Russian Federation. It's or for instance another type of neuroprotectors, ceftriaxone. They are widely used in the acute period, and this is, I believe, due to absence of evidence therapy. So people try to use what is possible. It's again private patient buy this. We were in our essayist campaign struggling with the wide prescription of neuroprotectors and redirecting people to the more evident therapies, but now you still can observe this implementation.
Great, thank you for the presentation. Appreciate you sharing all that.
Okay, I can starting, yeah.
I'm sorry, just quick. We have also from Kyrgyzstan Abay with a couple of slides. I'm very sorry, but Abay really prepared in advance, and we would like to quickly show a couple of slides. Please, Abay.
Hey, no, only for you. Okay.
Thank you so much. Thank you, Aida. Please, Abay. Yes, Abay, can you say something? Because I'm not hearing you yet. The microphone, please, on.
You need to unmute, Abai.
Yeah, Abay, please.
Yes, and now you can hear me. Yes?
Yeah, please, Abay, please proceed.
Okay. Good. 1 second. 1 second, please. Yeah, okay. First of all, thank you for this kind invitation and being a part of this nice event. First of all, I want to thank Professor David, as always. He's so kind, and our coordinator Inna. I will briefly talk about the situation. So for nowadays, we have totally 7 centers, and for the population of 7 million. 4 centers are located in the capital city, and 3 we do have in the second big city called Osh, something maybe California. Okay, and in the Bishkek city we have 3 public hospitals, totally 3 hospitals, and 2 are in the capital city, 1 in the Osh city, the second city, and we have 4 private hospitals. 2 are in the capital city and 2 are in the Osh. totally, the number of the specialists who can do neuro intervention are 5. So in these 7 cath labs, these 5 specialists are doing the procedures, mostly to the OSH. Most of us are flying there. So, and the achievement is for nowadays, we do these 4 types, the fields, I mean, brain AVM, aneurysm embolization, cerebral angiography, and carotid artery stenting. So up-to-date statistics are, due to we don't have a big data and database, we do it by the hand, asking these 5 specialists and collecting the numbers. For nowadays, from starting 2017, 2018, we did aneurysm embolization approximately about 495 cases totally for these 7 centers. And implantation of diverting stents, 41 cases, 18 cases for mechanical thrombectomy, 19 cases for the AVM, both pediatric and adult, arterial venosus malformation for spinal, 2 cases, and carotid artery stenting, 51 cases. Let me introduce some couple clinical cases. This patient, child, 11 years old, had a hemorrhage stroke, ruptured grade 3 brain AVM, as you can see in the video. The thing, when the patient was admitted to our hospital, there was separate consciousness, and the situation was really tough and hard. So we used the Onyx, and we, after 10 days, we totally didn't have any neurological symptomatic, and patient went home with the parents in a good condition. So for you can see the date in the right corner, 23 September. So it's almost more than 3 weeks, and the kid is don't have any kind of complication today. Now, the next case for the big aneurysm, 45 years old patient woman, and you can see the process of the embolization. We still have achieved the final result in the right bottom corner, you can see, but the aneurysm was really big. This patient with the unsuccessful clipping, the open clipping surgery was performed, but as we can see, the clip in the wrong artery. It was just investigation and the findings after the control checkup after maybe 5 or 6 years. So we did the embolization of this aneurysm. In this video, you can see the final result. And about the case for the mechanical thrombectomy, we do have a rare amount of them, only 15 cases. Was totally 3 hospital, 1 public, 2 private, did already a mechanical thrombectomy. As you can see, the final result in this video. So the toughest part of this is due to financial, we don't have any financial support from the government, and the patient have to pay everything by himself to cover this procedure. Thank you for attention, and I want to finish my presentation with the Benjamin Franklin's quote: "If you fail to plan, you are planning to fail." So we have to always plan our next step. Thank you very much.
Thank you, Abhay. So you can see our progressive cardiologist interventionalists doing a great work also for neurologists in Kyrgyzstan. And thank you, Aida, for patience. This was presentation from Kyrgyzstan.
No problem. With my pleasure. Okay, let's start. Okay, first of all, I want to say thank you for Professor David Libeskind that invite me here in person to be in the UCLA. It's a very beautiful place. And I want say hi for all our colleagues from the worldwide, as well my colleagues from the Kyrgyzstan and Abhay. Every year we meeting online. My colleagues from the Kyrgyzstan discovered several problems present in the region. The situation in Kazakhstan differs from our neighbors. We have already taken our first steps in in building a stroke management system, which we started building in early 2000s, and we have more than 70 stroke units, and more than 20 of them it's units of the third level. In my presentation, I would like to draw attention to the problems associated with the prevention of stroke. 1 minute. According to the official data from the Ministry of Health of the Republic of Kazakhstan, the overall morbidity of the population in our country from the 1998 to the 2017 of the population in our country, cardiovascular disease, which registered in the healthcare organization, has almost tripled in these years. During the period from the 2016 and 2019, hospital mortality increased by 13%, clearly indicating that hospital mortality is directly dependent on the rates of the hospitalized morbidity and the number of the stroke centers. However, in 2020, during the COVID-19 pandemic, the mortality rate increased by the 31%, despite lower overall morbidity of 2015.5 per 100,000 population. The trend has been observed worldwide. The decrease in inclusions is due to the COVID-19 pandemic, with a similar trend observed in other countries. Where we can see the increased burden of the healthcare facilities and reduced patient visits due to fear of the COVID-19 infection. This is two examples, one of them from the World Stroke Organization, which they reported that the sharp reduction in hospitalization for acute stroke patients in several countries, including Chile, Colombia, Iran, Greece, United Kingdom, Belgium, and Italy. And the second example, it's the example from the Rolling Guerra, global impact of COVID-19 on stroke care and IV thrombolysis. Also, I observed the similar trend. Based on the data from the Republican Coordination Center for Stroke, we can conclude that in Kazakhstan, the main focus is on providing highly specialized care for stroke patients in stroke departments of the second and third levels. The increase in complication of hypertension and diabetes, that is the increase in the incidence of the ischemic heart disease and stroke among the population of Kazakhstan, indicates that work of the prevention, treatment, and outpatient care at the primary level may not be at the desired level due to the various reasons. The slide presents two international studies which coordinated by the World Stroke Organization. The results of these studies showed that only 1/3 of the recommendation stroke primary prevention measures are implemented in 82 countries with low and middle income levels. In 2018, the World Health Organization do big report, which titled Improving Indication on Non-Communicable Disease, Barriers and Opportunities of the Healthcare System. It was noted that effective primary prevention and high-risk groups is not carried out in Kazakhstan. There is no systematic identification of patients at high risk, and their registration is not maintained in outpatient registers. The level of the coverage of patients from the extremely high-risk groups with the primary prevention measures are appropriate medication is unknown. Lifestyle counseling is not systematically included in clinical care protocols, and the responsibility for these services lies with the other agency. For example, it's an agency of the National Center for Healthy Lifestyle Formation, and therefore the corresponding opportunities may be lost. And they give some, and the World Health Organization focused in this report, focused the challenges in stroke prevention in Kazakhstan. It was a lack of funding for primary stroke prevention. There is no action plan for stroke prevention, lack for integrated approach to primary stroke prevention, low public awareness about the stroke, lack of monitoring system to assess the effectiveness of preventive strategies, and insufficient funding for stroke prevention research. And we, with my colleagues from our level, want to find some ways to solve the problems for reducing the prevention of risk factors and motivating the population to control them. We have some collaborations with the National Institute for Stroke and Applied Neuroscience with the Professor Valery Feigin. And we do some activities which are focused on the prevents of stroke in Kazakhstan in the framework of the trials of the Prevents MD. Prevents MD, it's a special software which based on the globally recognized stroke riskometer. For this software, we can use for risk assessment and clinical management that helps healthcare professionals optimize individual stroke risk assessment, manage risk factors for specific patient, and motivate patients to change their lifestyle. The main objective of the results was study to the satisfaction of the clinicians with the Prevent MD program, as well as the potential for using the program for stroke and cardiovascular disease prevention in Kazakhstan. This software is available in 10 languages, and we currently actively working to translate it to the Kazakh language. In the test version, the Kazakh language is already available. We approached medical professional. It was a neurologist, cardiologist, general practitioners with various levels of the experience, working in different clinical levels. It's maybe primary healthcare centers, private medical centers, city clinical hospitals. Each doctor has access to the Prevents MD software and worked with a hypothetical patient in it. After a certain period of time of the working in Prevents MD program, the doctors filled out some questionnaire. And this is some opinion of our doctors about this software. You can see that the level of the good opinion is big, yes. And here you can see the paper with the main results of our joint active with the Professor Feigin. We carried out this work with the participation from the 27 countries, which including in Kazakhstan. And in finally, at the end of my presentation, I would like to thank to the research team from Kazakhstan, Prevents MD Kazakhstan team, for their hard work and for dedication. And I want to say thank you for all Kazakh doctors, which are now sitting in Zoom and support me. Көп көп рахмет сізге. If you have question, please.
Hi, thank you for your presentation. Just a quick question. You mentioned that you saw a dip in stroke incidents during 2020 around COVID. Do you think that was due to underreporting during that time period? Have you seen like a change in those numbers since?
Yeah, if I understand correctly your question, I think it depends only about that in that time our patients thinking only about the COVID pandemic-19, yes, and they don't thinking about other diseases and the stroke causes too. Yes, that is why I think it's was low and more of my colleagues which are working in stroke unit in that times working in the red zone of the in the pandemic situation, yeah, working like infectionist more than the strokes neurologist, yeah.
Okay, well, thank you.
Hi, that was really excellent work on prevention. I'm just curious if you had any thoughts or information about the treatments like thrombectomy and how available they are for patients.
What kind of treatments we have?
Yeah, like for instance, the endovascular. If it's
yes, we have
the
the 3 levels stroke units. Ashfaq want to.
Yeah, no, I was very curious when you were showing your data of the stroke incidents. You know, you went from 1998 all the way to recently. Your numbers increased from 6,000 to 16,000. Was that because you were more careful in making sure?
I think it's like maybe in that time was first MRI CT scan come to Kazakhstan. Right. It was in 2000. Yes, and after that the level was more. Yes.
So you were just
and more attention, sorry, and more attention from the government about the stroke. In that time, in our Ministry of Health was very beautiful lady. She was a neurologist, and and I think it's that is why.
So she's coming next year to the meeting.
Huh?
We'll make.
Sorry, she's have some. She's not in life now, and yes.
Sorry.
But we are very appreciative of her.
So 16,000 patients, and what's the population of Kazakhstan?
It's a 19 million population. We have the huge territory, but it's for huge territory. It's a small population. Yeah.
Very informative. Thank you very much.
Another questions? Oh, my friend from.
Great. Yeah, thank you for a great presentation. Yeah, I was wondering about that. My guess will be life expectancy also increased probably during this period of time, and with increased life expectancy, there are more strokes probably. I mean, healthcare improved, right, in Kazakhstan from 98 to 2008.
Very important.
That resulted in increased life expectancy and more strokes, probably.
Yes, it's very improved, very developed. And in 1998, we haven't more equipment for the stroke. We don't thinking about the stroke. I think it's from this, yes, more. And now we have something more than 70 stroke units. And I think it's, yes, that is why.
Country is doing financially much better than in 90s, I could imagine.
Maybe, and and maybe we are more financially stable than our neighbors. Yeah.
Thank you.
Thank you for your informative presentation of Kazakhstan's the way the stroke stands there. So as I recall, you said you have 23rd level stroke centers.
More than 20.
More than 20.
More than.
And how many of them, the tertiary care centers, all of them have thrombectomy capabilities? Is that what makes them a tertiary care center in Kazakhstan?
It's like from the whole third level center in the worldwide. We do all things which do our colleagues in the third levels stroke units.
That is amazing. Over 20 thrombectomy.
More than 20.
More than 20 thrombectomy ready centers in Kazakhstan overall. That's a huge progress. As I remember, 10 years ago, you guys didn't have any.
How many? 5 years ago, it was something like 36, something like this one, 5 years ago, and now it's twice.
Yeah,
It's
great
growth.
progress. Continue to be the pioneer of the region, and also kudos to Ina and her colleague from cardiology for performing great things for
Yes,
Central
it's
Asia.
from Kyrgyzstan.
From
Abay.
Kyrgyzstan,
Yeah.
Abay. Yes.
Yeah.
Good job.
Thank you. Thank you. That's all.
Is this one, right? This one, or that one? Okay, let's go. Yes. This one? Right one. Good evening, everybody here. Good morning in Georgia, in that part of world. My name is Dr. Nadarishvili. I would like to thank Dr. Libesking for organizing this amazing 2 conferences and for inviting us here. My role here is I'm a U.S. license for Georgia for mechanical thrombectomy 2020. I'm closely collaborating with my Georgian colleagues, Professor Tsiskaridze and his team. So we will share this presentation together. But I would like to take this opportunity and show some research what we are doing in collaboration with George Washington University Milken School of Public Health. So we became lately interested whether post-stroke cognitive impairment is a risk factor for recurrent stroke. So that will be a discussion on this presentation and review of the data. So this slide shows American Heart Association's scientific statement on cognitive impairment after ischemic and hemorrhagic stroke. And it shows schematic presentation, complications of stroke in the first year. And you can see that post-stroke cognitive impairment here is prevalent somewhere from 22 to 80% of cases, and post-stroke dementia were somewhere from 7 to 41%. On average, paper quotes that approximately 60% of stroke patients have cognitive impairment at 3 months. So this same document pretty much describes management of post-stroke cognitive impairment, and there is no much information, unfortunately, here except secondary stroke prevention to minimize progression of cognitive impairment. However, the question is, does post-stroke cognitive impairment increase the risk of recurrent stroke? So to address that question, we conducted meta-analysis. We identified approximately 1,000 papers, and from that, 27 studies met eligibility criteria. And out of this, post-stroke mortality outcome was studied in 18 papers, and post-stroke cognitive impairment and risk of recurrent stroke in 9 studies. And here is a result of post-stroke cognitive impairment and risk of recurrent stroke. You can see 9 studies, 8,000 patients, and you can see that post-stroke cognitive impairment is associated with approximately 60% increased risk of stroke recurrence. And this meta-analysis includes, out of 9 studies, 5 are clinical trials and 4 studies are population-based studies. And there was no significant difference between clinical trial data and population-based studies in this meta-analysis. So regarding mortality, we identified 18 studies with 31,000 patients. And you can see that post-stroke cognitive impairment was associated with a 2-fold risk of death. So this is a very significant, and requires close attention and better studies. So in summary, based on this meta-analysis, we concluded that post-stroke cognitive impairment carries increased risk of recurrent stroke and death. Cognitive testing at 3 to 6 months, which was done in these studies, in 90% of these studies were patients evaluated from 3 to 6 months, can identify patients who might be at high risk of recurrent stroke and death, and maybe for whom more aggressive secondary stroke prevention strategies might be beneficial. Now, how to test that? There are 2 possibilities, of course, to do clinical trial prospective. However, we thought this is a paper by Dr. De Havenon from Yale University, and this is a this is a subgroup analysis of SPRINT trial. Remember, SPRINT trial was primary prevention trial and randomized patients in a very aggressive blood pressure management versus regular blood pressure management, and there was no decreased risk of stroke in overall population. Here, this is decided to look according to the mild cognitive impairment presence at baseline. And what they found, that they studied 5,000 patients, mean follow-up was about 4 years, and the risk of stroke was significantly lower in patients with a mild cognitive impairment on aggressive blood pressure management. And that was true after adjustment for other possible covariates, and there was overall 35% relative risk reduction. But again, remember, this is a primary prevention trial. So we became interested with this approach and decided to test that approach in a secondary stroke prevention trial. So we looked at the data from IRIS trial. IRIS trial was secondary stroke prevention in patients with insulin resistance and recent stroke, and patients were randomized with pioglitazone to placebo, and they had evaluation, and I will show more in detail on the next slide. So we aimed to study whether there is an effect modification of the treatment according to post-stroke cognitive impairment. In other words, to compare effects pioglitazone versus placebo in patients with or without post-stroke cognitive impairment. And this is again design of the study. You remember, as I mentioned, IRIS trial randomized patients with ischemic stroke and insulin resistance in pioglitazone versus placebo, and trial was positive. It decreased risk of stroke and myocardial infarction, but it did not decrease risk of post-stroke cognitive impairment. This medication, of course, in widespread use in patients with diabetes, but it was not used. It is not used specifically for stroke prevention because there was a other complications in this trial, and particularly fractures were more common in pioglitazone. That was the reason why it was not implemented in a routine secondary stroke prevention strategy. So data was available from 3,400 patients with stroke and insulin resistance. As I mentioned, cognitive testing, which was so-called 3MS testing. This is a more detailed mini-mental status examinations with a 100 point, and 89 was considered by study investigators as a abnormal. And as I mentioned, patients on average were randomized at 80 days. And there were 453 patients with a post-stroke cognitive impairment at baseline, and medial follow-up was 5 years, and there was 7.4% recurrent stroke, 7.3% death. And this is our data. On the left-hand side, you can see curves, and red curve represents a patient with post-stroke cognitive impairment, and y-axis is a pioglitazone versus placebo hazard ratios. And you can see dramatic decrease approximately somewhere starts at 1 year, from 1 to 2 years, and there is no difference at all in patients without post-stroke cognitive impairment, which is a blue curve. And there was a significant, statistically significant interaction between the treatment effect and post-stroke cognitive impairment. And that was statistically significant in multiple logistic regression analysis. And this regression analysis was adjusted for all possible variables, including age, race, ethnicity, years of education, TOS classification, hyperlipidemia, as well as treatment group. So this is the results on myocardial infarction. On right-hand side, you can see that there's a 77% relative risk reduction of myocardial infarction in patients with a post-stroke cognitive impairment, while in the middle column, you can see that there was no difference in patients without cognitive impairment. And on the left-hand side column, you can see that this is statistically significant, and this significance was after adjustment for all these variables, what was described before, and it's mentioned below the table. So what is the explanation of this? One possible explanation is inflammation. So this is a study from Singapore, from Dr. Chen's group, and they looked at the 250 patients with and without cognitive impairment. And what they found in a multiple logistic regression analysis that age, education, and pro-inflammatory interleukin-8 levels were associated with a higher risk of post-stroke cognitive impairment. And what is the concept behind that? This is an interesting review, mostly, of course, animal data. And the authors proposed this kind of mechanism associated with post-stroke cognitive impairment inflammation. So there is a pro-inflammatory systemic immune response that results in prolonged phagocytosis of ischemic core, which causes activation of the immune response. And there is a neurodegeneration with this, and dementia risk, as well as infarct enlargement in acute to subacute phase. Of course, that needs to be proven in the larger clinical study. This is all experimental data. So then how does pioglitazone works? Pioglitazone is, as you remember, PPR gamma agonist, and this is a data, relatively older data, 2006 or 2007, and this investigator studied effect of pioglitazone in a C-reactive protein. On the figure, you can see that at 28 days, there was significant decrease of C-reactive protein in pioglitazone group, and table shows that not only C-reactive protein was decreased, but matrix metalloproteinase 9, as well as monocyte chemoattractant protein 1. So overall, it has significant anti-inflammatory options. And given that there was decreased risk of stroke and myocardial infarction, it is likely that this is a systemic response, rather than something specific brain-wise. So in conclusion, pioglitazone treatment was effective at reducing risk of recurrent stroke and myocardial infarction in patients with post-stroke cognitive impairment. You can see that effect was present in a very small, relatively small sample size of 453 patients with this impairment, but there was no effect in approximately 3,000 patients. Post-stroke cognitive impairment may represent a potential biomarker for risk stratification in secondary stroke prevention, and this approach can be tested in secondary stroke prevention randomized clinical trial. Thank you for attention. Now I will pass torch to Professor Tsiskaridze to share his data from Georgia. Thank you. And I think we can discuss after Tsiskaridze's presentation. Thank you.
Thank you very much, Zurab. Can you hear me?
Yes, we can.
Let me share the screen. Okay, I think I can start. First of all, I'd like to thank organizers to inviting me to present again in this wonderful conference. I have to present remotely, but very much hope that we'll be able to be in person for the next conference. So I'd like to make a very brief overview about the situation in Georgia, especially in terms of neuro intervention in cases of stroke, and we called our presentation two sides of the moon, because we have some dark side as well as some maybe bright side, and I'd like to share it with you. First of all, some facts about Georgia. You can see here the area, which is Georgia is not a large country, with area of up to 70,000 square kilometers and population of 3.7 million, with capital Tbilisi, which is the largest city in the republic, with 1.2 million, and GDP is around $5,000 per capita. So we are now the part of the so-called upper middle income countries, and as in some other countries, 20% of our state is occupied, unfortunately, by Russia. What about some facts about Georgian healthcare system? This sector is well diversified in terms of number of participants and their market share. So the majority of healthcare settings are private in our country, so it leads to the high levels of competition between healthcare providers. And from 2013 to 2021, the number of healthcare service providers, because of that, increased together with number of beds. But the bad thing is that the average bed occupancy rate is quite low, at up to 50%, which certainly indicates inefficient utilization of resources. And another worrying number is that the nurse-doctor ratio in Georgia is very low. We have very low numbers of nurses. Many of those are going to other countries. If you this ratio is 0.98. If you compare it European Union, which has a ratio of 2 to 2.7, this certainly suggests potential strain on nursing resources, and certainly it has a negative effect on patient treatment and monitoring. Here you can see the top leading causes of death in Georgia, and stroke is on second place, as was expected. Okay, it's just to show the incidence of stroke. It's quite old data, but still We have one of the highest incidences if we compare it with other countries, European countries, especially, or countries of former Soviet Union. You can see the numbers, the figure here. And as to case fatality, on the beginning of 2000, Georgia was one of the leaders, unfortunately, in terms of case fatality. And now I'd like to show the recently published paper based on MT 2020 initiative, which we are part of, as was mentioned by Dr. Nadarashvili. You can see here that unfortunately the estimated, and it's based on the estimated percentage of patients with large vessel occlusion receiving endovascular treatment is quite low. You can see here this small red dot, which indicates that there is up to 10% of patients who receive the mechanical thrombectomy. This is another graph showing distribution of mechanical thrombectomy access on the basis of income, where somewhere in the middle, but with not higher number, about 8%, as you can see here on this graph. And the next graph is showing distribution of mechanical thrombectomy centers and operator availability. This data is based on the survey done in 2021. Situation is a little bit or quite different nowadays. I'll explain later on why it has happened. I represent, and my colleagues represent Georgian Stroke Association, and as stakeholders, we are actively working with the Ministry of Health together with hospitals, and we establish a task force for establishing criteria for primary and comprehensive stroke centers. And at present, all the hospitals in Georgia are undergoing certification, assessment, or monitoring by Ministry of Health based on this criteria. But unfortunately, at present, the stroke center status, either primary or comprehensive, has been assigned to everyone who's submitted an application to the Ministry of Health. And I'd like to highlight that formally fulfilled criteria for stroke center. And this formal criteria was based on equipment, number of personnel, availability of neurologists, neurosurgeons, CT scan, etc., etc. But the most important requirement still has not been installed. This, from our point of view, should be the national professional licensing of neurointerventional specialty. And this is absolutely important because the majority of these formal comprehensive stroke centers are staffed by very ill-prepared specialists, neurosurgeons with scarce or no experience at all, because for performing neurointerventional procedures, just to have the neurosurgery license is enough without any formal training after residency in neurosurgery. And the residency in neurosurgery very limitedly covers neurointervention in Georgia, unfortunately. What are the solutions from our point of view? Solution would be the introducing the mandatory and very strict professional licensing with the state codes, which should not be too many for specialists in neurointerventional therapy, which in turn will lead to increasing the procedure volume per specialist and increasing the quality of intervention. And as you can see here, how the situation was changed from 2021 to 2023. Again, I'm talking about stroke centers who were formally appointed to be stroke centers for this moment. For instance, the number of stroke centers, primary stroke centers in Tbilisi, which is the capital and the largest city, was 3. And nowadays we have 12 primary stroke centers and comprehensive stroke centers in 2021. The number of these centers was 9, and now we have 17. But again, I'd like to mention that these are the formally appointed centers who are not fully ready or are not fully capable of making endovascular procedures. And in reality, and this is a well-known paper published in European Stroke Journal, we need no more than 4 or 5 primary stroke centers throughout Georgia, and maybe up to 40 primary stroke centers, and up to 4 to 5 comprehensive stroke centers. So what we need, as I already mentioned, in total up to 40 primary strokes throughout the country. And paradoxically, nowadays the number of comprehensive stroke centers exceeds the number of primary stroke centers, which is absolutely beyond the reason, the twice higher number, and certainly it will lead, if our situation will not be changed, it will lead to dropping the procedures volume and decreasing finally the interventionalist skills. And the problem is also the mountainous region, which are not covered by any stroke center. And I'd like also to show how the situation is different for the patients getting in the so-called stroke-ready centers. And this is the data from 2021 until 2023, about more than 60,000 stroke cases. So on the left side of the slide, you can see the statistic for the centers who are well equipped and dispose well-trained and experienced staff. And it's sadly only 15% of strokes got to these 4 comprehensive stroke centers. As to the procedures, you can see here the percentage of procedures done in these centers, not too many. Unfortunately, 1.18% IVT cases, 1.3% EVT cases, and 0.5 combined cases. At the same time, other 45, I would say, wrong for hospitals who treated more than 50,000 stroke patients, which is 85%. And you can see here how low is almost twice low the number of IVT cases, and almost 3 times low number of EVT cases, and much more the EVT, and much less EVT plus IVT cases. If we look at the mortality, overall mortality after procedures are quite high, even in the well-trained centers. 30 days case fatality is 31% for endovascular treatment and 13% for intravenous thrombolysis, but situation is much worse in other 45 so-called comprehensive stroke centers who treated 85% of all stroke patients. And the hospital death rate is alarming, 73%, and there were almost up to 100% in some of hospitals, and for intravenous thrombolysis, the mortality rate was 21%. What about some other metrics? In right hospitals, answer to growing puncture time was 3 to 3.5 hours. Mean time. Answer to needle time 2.45 hours. Door to growing puncture time 1.25 to 2 hours. It's a little bit less than answer to needle time. It has its explanation, and door to needle time from 20 to 60 minutes, with a mean of about 40 minutes. As to the other hospitals, no exact data available, unfortunately, and some conflicting data based on statistics available. Door to needle time 40 minutes. At the same time, door to growing puncture time 30 minutes, which is really a little bit curious. What are the solution from our point of view? Certainly, it might be the implementation of national quality registry. We are now working very actively with Rescue. You know, this registry, which was distributed widely, and the Ministry of Health has the plan to adopt Rescue as a national stroke registry for Georgia. What about the reimbursement of stroke cases from November 2022? Our healthcare system switched to DRG system within the framework of the Universal Coverage Program. So intravenous thrombolysis treatment is fully covered by Universal Healthcare Program, and the diseases, the case of stroke is reimbursed. Reimbursement is about 6,000 lari. In some cases, reimbursement has been decreased to 3,000 lari. It's about 1.1 thousand US dollars. And for endovascular treatment, it's about 5.5 thousand US dollars. Maybe it's not bad. It's much better than it was before, but still there are some problems with reimbursement, because this DRG payment doesn't include devices costs. Because of that, our neurointerventionalists haven't disposed a wide option of devices. Therefore, they are not familiar with the tricks of each of those, and which certainly limits the range of manipulation. DRG also doesn't cover additional charges for ICU cases or complicated cases, which in turn could be the factor which interferes professional development of stroke specialists, especially for stroke neurointerventionalists. The solution which we are advising to Ministry of Health is to increase the payment per device. So I'd like to sum up what would be the next steps from our point of view. It would be of absolute importance to introduce neurointerventional state licensing with 1.5 to 2 years fellowship or specialization, subspecialization program, much stricter selection of primary as well as comprehensive stroke centers, and licensing of these centers, introducing stroke neurologist subspecialization, introducing and conducting short as well as maybe long hands-on teaching courses or conferences with with participation of partner organizations, introducing early rehab service for acute stroke, increasing reimbursement for EVT procedures and devices, and finally setting up National Stroke Registry. And by this, I'd like to thank you for your attention. I try to show the both sides of Georgian stroke care moon. And finally, I'd like to show the interesting picture of Nico Pirosmani, who was a famous Georgian artist, primitivist artist, the Fox in a Moonlight. Thank you very much.
Hi, thank you for that really interesting presentation. I had a quick question, and I don't know if you addressed it, maybe I missed it, but what's the incentive that's driving the expansion of the comprehensive centers over the primary centers? Is it that increase in EVT reimbursement, or what do you think it is?
Absolutely. That is the better reimbursement for EVT, which is, I would say, still not enough, but in the reality of this kind of different levels of different hospital, all these private hospitals try to have a little bit more money than they are receiving, and this is the main reason and main driver, as you mentioned.
Thank you so much. I had a quick question about the cognitive
Sure,
impairment as
go
well.
ahead, please.
Just maybe I'll just make sure I understood the beginning part, which was that after stroke, patients with cognitive impairment after stroke are at higher risk for recurrent stroke.
Yes.
Is that right? So has there been any thought or shown just the typical treatments for cognitive impairment, like, memantine or donepezil? Is there any thought that might improve recurrent stroke? You don't think
No,
that'll be the
actually,
cause?
there's no data that helps. I mean, it decreases progression of Alzheimer's disease, but not vascular dementia. Of course, it is prescribed, I mean, widely in this country, because sometimes primary care physicians are prescribing, and they do not differentiate, to be honest, vascular versus Alzheimer's disease, and frequently is prescribed.
Okay.
Thus far, we don't have any positive clinical trial. There was Signal last year, this year, phase 2 clinical trial, combination of antiplatelet medication named cilostazol and nitric oxide compound. There was some signal that improves outcome. I mentioned that there is some data highly questionable that cerebrolizine, which is a real brain extract, helps that. No, I'm serious. This was not Eastern European trial. That was international trial. So, but again, we are questioning that. Yeah.
Thank you so much.
Go ahead, please.
Thank you both for your insights. You mentioned that there is a discrepancy in care centers in the mountainous regions, and I was wondering if there was any data on stroke incidence in those regions.
I'm sorry, I missed the question.
I'm sorry. You mentioned that there is a discrepancy in care centers in the mountainous regions, and I was wondering if there's any data on the stroke incidence in those regions.
This question will be for Professor Tsiskaridze, please.
Yes, there is no exact data about the incidence of stroke in mountainous region, but certainly the stroke happens in these regions, and this might be one of the, because these are remote regions and it's difficult to access timely and to transfer the stroke patients from these regions. These regions are not densely populated, but still the cases of strokes then either are treated there without any intravenous thrombolysis and certainly without endovascular treatment. And some of those patients are transferred to other centers, but certainly Plenty of time is missed in almost every case, so this is still a serious problem for our healthcare system.
Thank you.
Thank you. Sandro, David asked me about a situation with the clinical trials in acute ischemic stroke. Do you guys do any, I know that you guys are doing some hemorrhage trials.
Yes, we are doing TEACH-3 trial nowadays about on hemorrhagic stroke.
For ischemic stroke.
No, for this moment, we are not doing any trial for ischemic stroke.
Okay. And what do you think, what will be that, what should we call washout period for these questionable comprehensive stroke centers, or what will be solution? There will be audit, my understanding is after 1 year, and then they will cut it down, right?
Yes, I hope so. Yeah, the Ministry of Health is doing very careful monitoring, and I think it will come to the realistic number. It will come to the realistic number at 1 year.
I believe realistically there are four in Tbilisi, one in Kutaisi, and one in Batumi. Is that correct?
Absolutely, and maybe one in Zugdidi, taking into consideration close location with Abkhazia region.
Yeah. Thank you.
Thank you.
Thank you, Alex. And thank you, Zurab. So we're going to go to Israel. We have Natan and Ronnie that are on. Natan, are you on?
Just unmute me. Can you hear me?
Yeah, we see you.
Good. Even you see me.
Yeah,
hello, everybody. Good evening or night. This is 7 o'clock in the morning in Israel. And we are in Jerusalem at the Shaarei Tzedek Medical Center together with Ronnie, Dr. Eichel, the head of the department, and also the Stefan Mausbach, Dr. Stefan Mausbach, who is the head of the neurocritical care and the stroke neurologist here. So it's a pleasure to be here in spite of the fact that I was supposed to be there in person. However, you are all aware of the difficulty in Israel, and we're trying our best to be here with you, although of the horrible things that are currently happening in Israel. And we all hope and pray for better days and peaceful days. So we represent Israel. I'll give you a very short introduction regarding, can you see my slides?
Yeah, we do, Natan.
Okay, so the stroke in Israel. This is, as you know, Israel is a very tiny, a little dot on the globe. We have about almost 10 million inhabitants now. This is 9.8 is the last consensus. But unfortunately, we attract a lot of attention, sometimes good, sometimes bad. So regarding the stroke organization in Israel, as you can see, currently we have about 11 comprehensive stroke centers and 22 primary stroke centers distributed along from north to south, from east to west, in various regions. Of course, most of the comprehensive stroke centers are in the region of Tel Aviv and the area. So what are the numbers? As you can see here, we have about 19,000 cases per each year, stroke and TIAs. We have a national stroke registry that we have. This is a continuous registry, so we know every year all the data regarding stroke and all the demographic and the other parametric. As you can see here, about 67% are ischemic stroke. We have in our registries 25%, 1/4 is TIAs, and the rest is intracerebral hemorrhage. This is the distribution of the age. Most of the cases are in the age of 60 to 79, as you can see here. And the female-male distribution are 44% female and more male, 56%. This is a very recent evaluation and analysis of the 2022 years. And this is if you look at the incidence rate, age-adjusted incidence rate per 1,000 is around 3, which is about 300 per 100,000 citizens, inhabitants. If you look at the admission, unfortunately, this is one of the problem that we are working on it, and the Ministry of Health working on it, that about half of the patients are, or 40% or so, are not admitted to neurology department unless to acute stroke units. So this is the thing that we have to improve. And we have, as the European Stroke Action Plan says, that we need 90% of all patients should be admitted to stroke unit. That is our aim as well. One of the things that you can see is just the trend of the reperfusion therapy. As you can see, there is increasing from 2014, where this National Stroke Registry started, to 2021 or 2022, about 18% of all ischemic stroke are going to a reperfusion therapy, about 12% IV TPA, and 8% thrombectomy. So this is the current status of the national map of the stroke in Israel. And I hope that we'll going to the right way. The current aim is to establish more stroke units and more comprehensive stroke units around the country. So with this introduction, I'll pass the microphone to Dr. Mausbach, who is the neurocritical care guy, that will introduce one of his interesting research study that he's conducting. Stefan?
I'm here.
Please.
Good morning, everyone. Let's see that you see the correct window. Obviously not. 1 second. You want this one? Okay. Good morning, everyone. Today, I want to present you a new marker for the outcome of lacunar strokes. So we all know patients that come in with lacunar strokes. It doesn't matter in which area. Some of them improve, some worsen. In this example here, I want to show you 4 patients with a lacunar stroke in the area of the pons. We see 4 patients. On picture A, we see a stroke that is not so big, but mainly in the ventral area. On B, we see a minor stroke closer to the midline. C looks very devastating. And D, it looks intermediate. It reaches the ventral area. So if we assume now which patient would improve, which patient would worsen, right from the picture, I would say A gets worse, B should improve, D should be stable, and C should be a catastrophe. If we look on the outcome, we see later, this is our initial NHSS. So as expected, we see higher NHSS with more ventral strokes in the pons or bigger strokes. But if we look now at the outcome of these strokes, we see a difference. So specifically C, the stroke that is very big, reaching the ventral area, improves. And the milder strokes that we see with B and D worsen. So is there a different kind of parameter that plays a role in the outcome of stroke? You all know CT perfusion. This is usually what we expect. We compare side to side, and we see hypoperfusion usually, and by that we estimate if we treat by TPA or endovascular. But we used a different approach. Instead of checking just one side, we decided to check the global perfusion. How does it work? Instead of comparing just one side to the other, we took the whole brain area and used that as range of interest. And by that, we managed to measure global cerebral blood flow and global cerebral blood volume for the whole brain, cerebellum, and brainstem. In total, we included 2,752 patients. All patients had to perform a CT perfusion during the first 2 hours after admission, and we had to use an MRI during the first 24 hours to see that it's really a lacunar stroke. We had a lot of exclusion criteria, and we threw out a lot of patients for confounders. Each patient at the end fulfilled all criteria. This also included having a vascular access in the same vein with the same flow on CT perfusion. In total, from this 2,700 patients, we could include 120, and we found two groups. One with a flow below 35 milliliters per 100 milligram per minute, and one group with 35 or more. Why did we pick this number? I will tell you soon. Our demographics show more or less similar demographics for both groups. We see a bit more of atrial fibrillation in the higher CBF group, and we see a bit more cardiovascular risk factors like dyslipidemia in the low CBF group. The strokes are slightly different. We see more strokes in the area of basal ganglia and capsula interna in the high CBF group. We see more corona radiata and slightly less in pons in the low CBF group. When we look at global CT perfusion, this is what we measure. And if you look at it, there's not a big difference between A and B. Yes, on B, we see it's a bit more blue. And this is nothing you measure just with your eye. So A is a patient that has a completely normal cerebral blood flow above 40 milliliters per 100 milligram per minute. And picture B shows the cerebral blood flow of 25 milliliter. But this is something that needs to be measured, not by eyeballing. So we measured all our patients and we measured the cerebral blood flow. And what we see, the average cerebral blood flow is around 37. As we see, the first cutoff here, where the drop starts, is around 35 milliliters. So this was our cutoff for further classifying the patients. When we look at all patients together, we see first of all, in the higher CBF group here on the left side, that patients come with a lower initial NHSS and a slight improvement. If we look for the other patient group with low CBF, we see that these patients come in with an on average higher CBF, and they show a more drastic worsening of their stroke symptoms. When we look at the outcome regarding region, we see for low CBF, it doesn't matter where we look. If we look at the thalamus, internal capsula, other basal ganglia, corona radiata, or pons, we see a worsening for all stroke areas. When we look at the patients with the high flow, we see stable patients or slightly improved patients. We only see worsening in the area of pons, but that is something we expected, as pons and internal capsula are prone for worsening. If we look at a spiral chart, let me explain you quickly. We see in all the patients here that were included in the study with the low flow. And you read the spiral chart clockwise. So we have NHSS from 0 up to 16. And all the red lines are patients that worsen, all the blue lines are patients that improve, the dots stay stable, and the black lines are not significant. So we see a lot of patients with higher NHSS score, and show a higher rate of worsening. Like if you follow the lines, we see worsening from NHS 6 to 16. This is something that is very isolated in these patients. When we look on the other side, these are the patients with the high CBF. So most of them are related to the right side, so lower initial NHSS scores. And we see all the blue lines are patients that improve. So we see a high rate of improving. And if you look at the inner circle, those are the only patients that worsen. And even if you look how much they worsen between 2 and 4 points on the NHSS scale. So a huge difference between both groups. So we postulate that global CBF can be a prognostic marker for the outcome of lacunar strokes in the first 48 hours. Thank you very much.
Okay, hello. Hi, my name is Dr. Ronny Eichel. I'm the head of the neurological department in Shaare Zedek. We actually all here in Shaare Zedek in the moment, which is in Jerusalem. 1 second, I'm trying to share my screen again. Just to make sure everybody sees the screen and hears me. Hello?
Yep.
Oh, thank you. Thank you very much. Okay. All right. So you can see on this picture our hospital here in Jerusalem. It's in the middle of the Jerusalem next to Har Herzl. And you're obviously very much invited in the future when things hopefully is going to be much more quiet and peace around us to come to visit us. So what I'm going to present is maybe a little bit a new approach to try to improve stroke outcome. Okay, and as I'm a little bit already in an age where I started my residency in Israel when there's still IVTPA only started. I actually started my residency when the first IVTPA was given in Israel. That was 2002. We started in a time where we more or less didn't have anything. Just IVTP started, as I said. And endovascular intervention was still not on the table. We very fast after this in Israel, there were first centers that did EVT, but very limited. So from nothing to something, and obviously that something is, we can today very good identify our patients that are eligible for interventions, especially for endovascular interventions, by selecting them very clearly by the guidelines with advanced imaging and CT perfusion, and that's great. And we get really good results if you think about other treatment effects in medicine. Okay, we have an effect of 46% of patients that are becoming independent, which is great. One of 2 patients that will undergo these interventions will improve. But isn't it funny that we really highly selective choosing our patient, and still we get only we got this number. We got only around 50%. Okay.
Hi, Roni. Just want to know that you're not advancing your slides.
Oh, sorry. That might be the problem here with the. Then I will change it to. Okay, sorry. Can you see now the slides in that way?
Yes, we can.
Click again on
Yes.
screen sharing and pick a different screen, the screen that shows the presenter mode.
No, I'm going to go like that for sure, so it's not going to be a problem. Okay. So nothing or something. Okay. We said about how we are selecting our patients, and it's weird that we are highly selected for our patients. Still, it's only 50% of our patients. And this is weird. It should be better because we have chosen patients that are clearly should have a benefit because they have a penumbra. And the results, the reasons for that are very different. Okay, so we have obviously the question how good we were in recanalization and how good we were after, even when we recanalized and opened up the artery at the obstruction. Is there good flow? Is there good flow afterwards? Do we see that there are more obstructions? Okay, because the clot disrupted. Okay, or there are more problems, or we couldn't open up the artery fully. Okay, so all these things obviously will be effective. Okay, will be having an effect on our outcome of our patients. So this is clear. This is something very mechanically. It's easy to understand. But secondly, there's something that is called no-flow phenomena, post-EVT no-flow phenomena. And for the cardiologist, that is a very well-known subject that was already investigated. And here, actually, I show you a picture of a cardiological intervention. And you see that the pathophysiology causing even though that we recanalized in a good way the artery that is obstructed, still we have a lot of problems that can have in the downstream area after the obstruction. And you see this is a problem, obviously, of hemorrhagic transformation, okay, of edema, okay, of blood-brain barrier disruption, of microvascular plugging, of just a thrombus, of spasm. Okay, so there are a lot of things happening behind the scenes and after the occlusion. Okay, and so we know about this, but actually we don't do anything in the moment for it. And when we look on neuroprotection mainly is addressing things that happen before we even give revascularization treatment. And so the idea is maybe we have actually to give our treatments, okay, after the revascularization because then we are maybe able to deploy our treatment in the right area because we have an open artery. So this is the idea and the hypothesis after our study that we developed now. And for this, just to understand, we would have to measure, right? We would have to measure, first of all, okay, what's the situation of the brain after we revascularized, okay? And a very nice study in 2020 done by Marta and his group in Barcelona showed that we can, by CT perfusion after endovascular intervention, we can measure what is the cerebral blood flow and the perfusion after these kinds of interventions. And you can see on this diagram that there are a substantial amount of patients that after they were revascularized perfectly by TK2B3.
Hi, Ronnie, so sorry. We're stuck on slide 7.
You're still on slide 7. Oh, what is that? It's not advancing in the moment?
You're progressing now.
Yeah, okay. Where are we now? Do you see the diagrams of the group of
How can we measure?
How can we measure the problem?
Yes, we can.
Okay, thank you. So this is a diagram showing that even if you have a TK2B3, you still have a substantial amount of patients that have a CT perfusion, an unfavorable CT perfusion after endovascular intervention. And these patients are in risk and are very much higher risk to have a bad outcome. So this is a very important work done in Barcelona, showing that we can measure that problem, okay, by CT perfusion after endovascular intervention. Can everybody see the next slide?
Yep.
Okay, sorry. So we were thinking about what could we do and what substance to use, okay, to have an intervention to improve the situation of those patients. And cerbolazine is a very well-known intervention. It's actually recognized and recommended for rehabilitation after stroke in various areas in the world, in Europe and in Canada. And and we have a lot of data over because a very quite old medication already. A lot of data showing us what is the effect of this medication. And we know that this medication, first of all, has an effect for stroke patients, especially if you give it early. And we have data clinical data, and we have clearly also data on preclinical data showing that time is also of essence when giving this treatment. The way of cerbolazine affecting, actually maybe the clinical effect is most probably some kind of neuroprotection. We know for sure that one of these actions are on the blood-brain barrier disruption and a protection of the blood-brain barrier disruption to decrease actually the edema. And we have data on this, also preclinical data. And so we choose that medication, to see if we can intervene. So our pilot study that we are conducting, is trying to evaluate this effect, and they evaluate the effect of safety and efficacy of cerbolazine after acute ischemic stroke and AVT. And the idea was, and what we tried in the beginning, I have to tell you, try to do it, I think, elegantly. We wanted to check the perfusion while we're giving this treatment and doing a sequence of perfusion imaging to the brain while the patient is getting the cerbolazine. And to do that, because to do this by CTP, that wouldn't be possible, and to do gadolinium injections, recurrent gadolinium injections, it would be also not okay. We used a new system which is called spin labeling. It's not so new anymore, but the idea is actually to label the protons in the cervical area and then to measure the same protons that arrive to the brain, and by that creating perfusion imaging. So the idea was to, after EVT, to put the patient in the MRI, perform such a perfusion imaging, then to give cerbolazine, and right afterwards again to perform perfusion imaging by spin labeling. So I'm not going too much into the study. Here are a couple of examples of our first patients that we performed such imaging. And as you see, here is a patient that had very small diffusion deficit after his endovascular intervention. And when measuring the cerebral perfusion, we couldn't see any changes. Obviously, this was also very, you see the resolution is very low, and also the deficit, that would have to be measured was very low. So we couldn't see here any difference. In this patient, also very small diffusion deficits, but here we saw some difference, but unfortunately there was no difference between the two pictures, I mean with the picture before the cerbolazine and after the cerbolazine. The same is true for posterior fossa stroke, posterior circulation stroke. Also here we couldn't measure too much difference. So unfortunately, it's also a very difficult way to do because all these patients has to be a lot of times still intubated and sedated with an anesthesiologist. It took so long time to do all this stuff. So we decided in the current situation to drop this approach of measuring the effect of cerbolazine. And what we decided is to change our approach and do CT perfusion after endovascular intervention on the bed of the patient, on the bed of the angio suite, which is possible to do, and then afterwards give the patient cerbolazine, and then see which patients are affected by the treatment in comparing the various groups between the unfavorable and favorable post-EVT CT perfusion measurements. So this is just a new undertaking that we did now, and we hope this will bring us data of seeing if we can find treatment, effective treatment after post-EVT, and by this affect actually the outcome of the patient, even though they have maybe an unfavorable post-EVT CT perfusion. Thank you very much.
Thank you. There time for questions. Ryan, David, or which is.
So, good morning. Those were excellent presentations. My question was to the second presentation about the progression of lacunar stroke-related symptoms. I'm intrigued and I'm actually very impressed. What I couldn't understand, and perhaps if you can explain it to me, when you measure these global blood flow, how do you do that? When you say it's under 35 or more than 35, is that simple enough to do? Because if the outcomes are so significant, it should be a very simple test.
Yeah, it is a very, very simple test. So basically, we go into the pre-testing of the CT perfusion. So we take the raw data and those we analyze. But instead of putting in a midline to compare the sites, we leave that completely out. We take automatically the whole area as range of interest and then copy that to all the 4 measurements, and then it automatically measures it. It's that simple.
And why is it low? I mean, I can't figure it out. Usually you would think, I mean, I'm being very simple, if it's low cardiac output or significant intracranial, extracranial arterial stenosis, how do you, what's your theory as to why is the global blood flow low?
Like, we excluded every patient with stenosis is above 50%. So I think it's we excluded all. Yeah, I see a delay. Wait, I take the video off. Maybe then it's faster. So we excluded all patients that had an extra intracranial stenosis of more than 50%. I think it's a pure cardiac output problem, and that's our follow-up study.
So, Stefan, that would be so important to know, right? If, and it should be simple enough, if their cardiac function is good, then you have you've got a problem at your hands. How do you explain this difference? It may be something very simple, but definitely very, very intriguing. I'm going to let you think about it, but I just wanted to say hi to Ronnie also. Long time since I've seen him, so.
Thank you.
Hi, thank you for sharing your work and obviously a heartbreaking and difficult time. I actually had a similar question, so I apologize if it's kind of repeating it. You know, as a resident, I'm often reminded on wards that CT perfusion is not appropriate for posterior circulation, but obviously in this study we're talking about global perfusion, but we're still looking at posterior circulation stroke. So I just want to make sure I understand that we're not at all localizing to the posterior circulation in terms of this global hypoperfusion. It's a general hyperperfusion because of this, I guess, possibly cardiac state. Am I understanding correctly?
You're completely correct. So I just picked for the pictures the posterior circulation. Yes, it's clear. There is a completely different posterior circulation than anterior circulation. But we see the same results in all patients, and simply these pictures were more dramatic.
Thank you.
Zurab Nadarishvili, George Washington University, great presentations. I have a question and comment about second presentation. We did study together with NINDS intramural branch on anterior choroidal artery MRI perfusion. And what we found that patients with a perfusion deficit in anterior choroidal artery had worse outcome compared to those without it. And I was wondering if this is related also to your research. Thank you.
Yeah, thank you very much. It is known that as soon as you see a lesion on CT perfusion, this is a marker for worse outcome. But I didn't mention it, those patients we excluded.
I see. Thank you.
Maybe to give you
Thank you so much, Nathan, Ronnie, and Stefan. So we're gonna switch to the next session. Stay safe, and our best
Okay.
wishes for you. Okay.
Thank you very much, guys, and enjoy the rest of it.
All right. Take care. Sean, can you go to Apostolos?
Hey, Apostolos, please feel free to share when you're ready.
So hello, good morning from Greece. Are you hearing me? Are you seeing my slides?
Yeah, perfect. Go ahead.
Yeah, great. Thanks a lot for the invitation. I'm very happy to be part of the Collaterals this year also. So I have no conflicts of interest regarding this presentation, and I'm going to show you an update on the status of endovascular treatment in Greece. Despite the fact that in recent years you had a quite rapid increase of IVT delivery, starting with, and we have been registering our progress with the SITS registry. We lag behind implementation and access of stroke patients to thrombectomy. The whole effort started on 2017, registering the cases and the patients, and we have presented our first result using the SITS registry, and then after many years, we only had a couple, 300 cases of patients treated. So it didn't go very well up to now. We had a lot of problems that have been mentioned by other presentations in other countries, such as the fact that there is still no DRG for endovascular treatment, and we lack in cath labs and interventionalists. There was this projection in this paper back in 2019 that we should have 5 centers and 28 stroke units. But despite the fact that we have many more centers now providing mechanical thrombectomy and providing intravenous thrombolysis, we still lack a comprehensive national plan to implement and form a network out of these centers. As a result, Greece fares worse than a lot of upper middle income countries, despite the fact that Greece is considered a high income country. We have the first signs that this is changing this summer with the announcement by the Ministry of Health that a national network of 7 stroke units will be constructed. Of course, some of these units are already working, but they will be reinforced with personnel and funds in order to provide whole coverage of the country. So by having 16 or 17 stroke units with 6 beds per unit, we estimate that we're going to treat in these newly formed stroke units up to 7,500 patients per year. And according to some recent epidemiological data, we have one of the highest prevalence rates of stroke in Europe. So we really think that by having a stroke network, we will reduce mortality and disability. Now, about the rest of the country, there is not a lot of effort. So we have some data from the rescue registry, but once again, as we see in other countries, we have data from the university centers where they will receive extra funding by the state to further develop their stroke care. What happens about the periphery? It lags behind, obviously. So we have considered and we have started now developing a mapping tool in order to provide the rest of the country with information about the availability of the stroke units and stroke centers. So centers providing IVT or endovascular treatment. It will be a simple mapping tool that will have but it will have a real-time information because in the Attica region, for example, around Athens, about 4 million people living there. There must be at least 20 neurology clinics providing IV TPA, and up to 5 or 7 clinics providing mechanical thrombectomy, but they do not provide service every day. So if a center has only one interventionist, as you may imagine, it cannot provide 365 days a year mechanical thrombectomy. So we need to put this information inside the application in order to have a physician having a stroke patient, an acute stroke patient, the information on where to turn and where to send the patient for thrombolysis or mechanical thrombectomy. So we do not have a stroke map, a national stroke map, like in Catalonia, for example, like Switzerland or in Germany. And because this is centrally priced, so we are trying to find a solution to this problem. The rescue initiative, we use it also, but it's not complete like in the Czech Republic where it started. In Greece, it's also only minority of the stroke unit. And there is the European Stroke Organization certification map, again, just showing the tip of the iceberg. There is only a couple of centers in Greece accredited by the European Stroke Organization. And there is also the Angels Initiative problem mapping tool, but here it shows all the centers. Also, it is only centers that voluntarily participate in the initiative are shown. So it's not just that it's showing a part of the picture, but by showing the centers at large, doesn't show which center at which day is active. So you cannot use this map. We hope that we will expose inadequacies of the current system and show the gaps in the country and in the time frame in order to further strengthen the forming now stroke network. We have to fight the top-down approach to form a committee to, in the Ministry of Health, define goals, discuss resources, and then find a compromise. And eventually, if you are lucky enough to have some changes before the next elections come. So we hope that digital tools may provide this opportunity for a bottom-up approach and make all the dots form a network, the different parts of the country working and forming a network to cover the country. Up to now, unfortunately, most of patients in Greece still receive care, acute stroke care, in clinics where even no IVT PA is provided. So this is basic stroke care. More and more we have IVT clinics and we hope to upgrade them. And we have collaborated in the European Stroke Organization Certification Committee with the Angels Initiative in order to take these IVT clinics and make them stroke units with SOPs and specific time metrics that you can follow. So the ISO Executive Committee has provided a waiver of 90% in the administrative fees to get certification by the ISO for any site that has an Angels Diamond or Platinum Award. So any center that has shown that it's committed to provide metrics and follow the quality of health they're providing. And of course, in the following years, we have the challenge to have to construct more thrombectomy capable centers because thrombectomy, as you all know and agree, is the game changer. So digital tools may help integrate the different centers into networks. And part of the program of this program that I have mentioned by the Ministry of Health is also to provide the 16 or 17 centers with software commercially available that will provide multiparametric CT imaging in these centers, but still you have the problem that the rest of the country will have only a CT. So our hope is to have this mapping tool and provide it to periphery hospital settings, and then maybe in a year from now have some data collection about how patients are transferred, because even in the centers that they perform currently mechanical thrombectomy, practically more than 90% of patients treated are the patients arriving to the center in the as a first intention. Transfers are rare, and if we do not increase the transfers, we will not have an increase in the patients treated, even if we increase the number of centers. And probably we hope that in a year from now, we will publish a report about the impact if everything goes well. And of course, this data can be used by policymakers to further strengthen the network and develop stroke care. And hopefully there will be access to this application to the EMS personnel, which is our final goal, in order to have a quick transfers of LVOs to the centers that they may be treated. We have applied for a grant from the World Stroke Organization to provide an international version of this application to countries where there is currently no national comprehensive stroke center, and countries, there are many countries in crisis, so you may have, as part of your network, a part of it not working due to shortage of local resources or power cuts or aggressions. So you can input this information directly into the system, and each user may see real time which part of the network is working and available to accept the patient. And with that, I will thank you all for your kind attention. Thank you.
Thank you, Apostolos. That's excellent. You're making a lot of progress in Europe. Radu, are you on?
Yes. Hello, everybody. Good morning. I'll just share my screen.
I apologize. Tutor, I think he's getting on a plane.
Yeah. We are. I am in Montpellier already, preparing for the slides, and he's coming also.
Oh, okay.
So
I'll see you remotely tomorrow night.
Yeah, with the results of the last trial. So I will briefly give you some slides and some small talk about how developing of EVT in Romania is going, and then I will touch on a topic that interests me lately of tandem occlusions. So I will start with this map. This map, we work together with Professor Costa. It's a real-life thrombectomy map showing the number of thrombectomy and the rate of thrombectomy from all strokes in different departments. And the aim of this map is to be able to compare your country to the countries around you, and to compare inside the departments what is the rate currently. Now, when you look at Romania, you can see that there is a small thrombectomy rate everywhere. There are 5 functional stroke centers with a 3% thrombectomy rate in the region, or even smaller. Some of them are not performing all the time. My hospital, in which I started to work back after I was gone for 2 years in Bucharest, has a thrombectomy rate of 3%, and we're actually covering, it's the only hospital that really does thrombectomy in the south of the country and in the capital. We will be able to see the roads on this map. We will be able to see the primary stroke units, and then to plan and use it as a way to reinforce government policy and whatsoever about where new stroke centers are needed. We made a quick progress with EVT in the past few years. We arrived at good overall rates in the different EVT centers. We're kind of limited in some regions by the low number of neurologists. A lot of Romanian neurologists going to work in France, Germany, and other Western countries. So we're kind of stuck behind around that. Now, in terms of endovascular treatment, we are very bad, as in any Eastern Euro country, I believe, except Poland. So we have a national thrombectomy rate of 1%. We have the 5 hospitals and 3 active. But we have some good news, and that good news is that we managed to open 3 active centers. They started in October. Some of them already started treating patients. Some of them will start in the next month because of accreditation issues and problems like this. They are well staffed with active members. So with this new hospital inside the system, we hope that next year we can speak about the doubling of thrombectomy rate. We made another big breakthrough, which is small for US or for other regions, but in Europe it's something very rare, and that is that right now every neurologist, neurosurgeon, cardiologist, or radiologist, of course, can be accredited to do neurointervention in Romania, and neurologists, neurosurgeons, and radiologists can also go to do a step further, to take the second step and be able to treat any intracerebral vascular pathology like AVMs and aneurysm. And This permitted us to start training people officially, to have neurologists and neurosurgeons in training. The first 7 will start in November, and this will staff the existing center more, so it will help our increase of thrombectomy rate in our country. Now I want to go back to tandem occlusions because when I got back here in Romania, I noticed that we lacked GP2B3 inhibitors, we lacked IV aspirin, and the outcomes in the literature of occlusion of a stent were like 20%. And I just wanted to see, okay, what happens with our patients, the patients that we did, because we had a local protocol of aspirin and clopidogrel. And what can we do actually about it? As you can see, if your stent gets occluded, actually your mortality triples and your good outcome halves. So I found Cangrelor in Romania, which is most parts of the country very expensive drug, so I could use it. So I wanted to see what happens in our cases. So out of our thrombectomies in my hospital, we had 24 hours occlusion, stent occlusion rate of 70%. And then I wanted to compare in order to convince my colleagues that the Cangrelor strategy is a good it's a good way to go, because there's not so much literature data about that. I wanted to compare them with the Montpellier cohort. And you can see people are older in South France because of olive oil and exercise, and not like in Eastern Europe, but overall they had much lower stent thrombosis. And this much lower stent, this is an article from the literature which just compares symptomatic intracranial hemorrhage between groups of Cangrelor and DAPT for acute tandem occlusions. They looked the same, but they had just 30 patients out of, I believe, there were like 30 centers, which included patients in this study. So it was a multi-center trial recently published, and not a lot of data actually about Cangrelor in tandem. So in my cohort, we had like 100 patients. And we had 40 patients with Cangrelor and ticagrelor. We had 40 patients with DAPT and around 60 patients with GP2B3A DAPT. These were distributed as follows. Most of the Cangrelor patients were in Montpellier, because starting 2018, they switched to a complete Cangrelor protocol for every tandem occlusion, which they put a stent. And in Bucharest, most of the DAPT patients, because starting with 2021, GP2B3A inhibitors were not available in our country, and this coincided with the rise in thrombectomy rate in my hospital. So when we looked at stent thrombosis, we saw that there's a big difference, and that most of that Cangrelor results in a much lower stent thrombosis than DAPT or GP2B3A and DAPT. Now with GP2B3A, I would be worried because it's older data also from Montpellier and from Romania, and this might have been used. This might have been used as the rescue. I do not have data about that, but definitely we can see the impact of using Cangrelor and ticagrelor strategy. The fear was always the hemorrhagic transformation, which I showed you in an article based on 30 patients that it was the same. My results are kind of the same based on around 100 patients divided in these 3 groups, so not much more hemorrhagic symptomatic transformation. But what is to be seen, and I would like to take to know if you have experience with that or you know data about that, is what happens to stroke patients after 48 hours, which are let on ticagrelor, because we do not I do not have the data about that. Do they bleed in the first week with big strokes? Should we worry about that? And now, just because I always heard that Cangrelor is expensive, and I thought at the start when I found out that Cangrelor is expensive in Romania, actually, if you use the cardiac doses, it's very expensive. But one study that we did using low-dose intravenous Cangrelor in neuroendovascular procedures, like actually more than quarters the initial dose, and it halves the infusion dose. And we had great results with very now testing and everything. So if you do that, the current price per patient is 100 euros. So Kangaroo, I don't think is a problem. The only idea is, will it help patients in different settings where GPT-B3A is not available, or there are several problems with taking it. And with that, I thank you for your invitation. And if you ever want to visit Romania, please contact me.
Thank you very much, Radu. I think we have the great tutor Joven, who will soon be in France with you, if he wants to comment.
Yeah, hello everybody from the airport.
Of course, in the first class lounge. No?
No, at the gate. Nice presentation, Razvan, although I only saw half of it. It looks like, and I know that you guys are making good progress in Romania with respect to acute stroke treatment, especially on the IV thrombolysis side. What has been your experience in this first year since you went back home? What do you think are the biggest barriers in treating patients with stroke? With thrombectomy in Romania. One thing is not a problem; it's the lack of patients. That's never a problem over there. So, where are the barriers, and how do you plan to address that?
I think coming back right now, the biggest problems is if before we had problems with resources, now we still need more people. But speaking about my hospital, I think we could double the thrombectomy rate. But the problem is we're not getting called as often. So LVO strokes are not diagnosed as LVO strokes in stroke units around, because they were used to not having EVT treatment. They're done doing contrast, and it's always the same hospitals that call us for thrombectomy, and actually the same neurologists that call us. So it's not a rule that every stroke that gets into a primary stroke hospital in Bucharest will get an angioscan or something, a diagnosis of LVO, and he will be sent to us. This is the biggest problem. If we had that, I think we could easily double thrombectomy rate in our centers that are actually working right now.
How about pre-hospital, the pre-hospital scene? What can be done there? Why should these patients go to the non-thrombectomy centers to begin with? Is there a uniform pre-hospital system in Bucharest? Is there a way to make paramedics bring patients, train them with race scale or some other pre-hospital scale, and have the worst strokes come to a thrombectomy center?
Tutor, our Radoslav has suggested fast AI for Romania, by the way.
Yeah, we were thinking about fast AI for Romania, like meetings technology and things like this, but this will have to be included, and this would have to be financed, of course, by the government in order to put it. And it's not that easy to obtain financing for software by your government in countries like us. But regarding the pre-hospital problems, we worked on a project before the pandemic of RayScale, which was approved. We started training people for RayScale. The problem right now, or the biggest problem that people fear in my department, especially the neurologists, that if we do that, if we train the people from the pre-hospital to bring us the severe stroke patient, we won't have enough patients, we don't have enough beds to put all of them in. And there is no way, because once you train people from the AMS and they see that the hospital is performing, we saw this with thrombolysis several years ago when we were the first hospital who was moving, they start bringing everybody to you because they think that you will make him better. So then you run out of beds and you have no way of dealing with this. So this is, it has to be coupled in a way with a reimbursement system when I can do the thrombectomy and send the patient right away to another
Yeah,
hospital.
repatriation, even after thrombectomy,
Directly,
in some
not
places, in some
directly, not
places, patients are sent back to whatever, primary center or non-thrombectomy center. Lots of issues.
yeah, but it's problems to solve. So it's exciting in a way.
Excellent. So Radu, thank you very, very much. Tutor,
Thank
safe
you.
travels, and we'll see you virtually.
Thank you. And,
looking forward to Slice.
and on this collateral talk about Romania, I'm actually the one who's in Romania. So just for the record.
But now you're in Newark or somewhere.
No, I'm in Bucharest. I'm waiting to go. To go to Slice.
Oh, you're in Bucharest going to. That's right. All right. Well, good night, guys. Thank you so much.
All right, very good. Well, thanks for having me.
Thanks for having us.